Members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. Apologies received? None? Okay. Anybody aware of any apologies? None? Okay. So, in terms of Chair's business, can I just begin by thanking Common Youth for hosting the committee this morning. Myself and Danny were there. It was very informative. So there may be further correspondence and actions as a result of that visit, but it was a very useful opportunity to engage with them and find out what they do. Can I also thank members for meeting with Emer's Wish on Tuesday, who are campaigning to promote stem cell donation. I think again that was a useful informal engagement, and if members are content on the back of that informal engagement, or if you're content, we would like to write to the Minister for information on the work the Department and the Public Health Agency are taking forward on this particular issue and what discussions they have had with the Minister in the South for Health in relation to an All-Ireland register. Everybody content? Linda?
Yeah, no, more than content with that, and just I know not all members were able to. It was a sitting day and it's hard for everybody to be able to meet everyone, I know, but I would just encourage any members that weren't to go and look at their social media, and if we can, share it and encourage as many people as possible to be on that register. It's a potential to save somebody's life, you know. I just think that it costs nothing and it can make a big difference to a family. I mean, both of the people we were speaking to lost their children at different stages of their lives. A little boy who was only 4 and Emer then, who was a very young woman. So I just think that what we can do, or anything we can do in terms of sharing that social media to encourage people to be on the register. And I think one of the things they said to us is people hear stem cell and they think it's more than it is. This is about bone marrow. This is about saving young people who have blood cancer.
Yep. All good. Yep. The other thing, just to alert people to, I attended a Living Wage NI event this morning. Purpose was around obviously trying to bring about a living wage for social care, social healthcare workers, and there was engagement from policy people in Scotland and Wales who are obviously have that in place. So again, very useful, also very timely given the presentation that we have this afternoon. So that's just for people's information. Draft minutes then, can I refer people to the draft minutes of the meeting held 15th of May? It's page 6. Everybody content with the draft minutes?
Right.
Yep. Okay, matters arising? None? Okay. Okay, so we have an oral briefing now, item number 5, an oral briefing from the BMA NI on general medical services contract proposals to GPs. So the committee considered correspondence from the BMA at last week's meeting, and obviously in the back of that agreed to invite the BMA to brief the committee today. Obviously, in the intervening period, we've had a statement. So can I refer members to tab 5, including written ministerial statement, and that's at page 20. We have a response from the Department following the meeting on the 1st of May. And if I could welcome Dr. Frances Hagan, Chairperson of the BMA, and Dr. Kieran Mullen, the Deputy Chairperson. So just to remind everybody, we have an hour for this session. I'm going to hand over to yourselves just to make an opening statement, and then we'll get down to questions.
Thank you very much, and good afternoon everybody, and thank you for inviting us at this really pivotal time for general practice in Northern Ireland. We meant for today's evidence session to be a chance to update you and your constituents on the negotiations for a 25-26 contract. However, it's safe to say Monday changed all that. My colleagues are deeply saddened by the Minister's statement on Monday. His dismissive comments and at times flippant tone showed just how out of touch he is with his officials about the crisis that's going on in general practice at the minute. It is difficult to think of another profession anywhere in the health service that has been spoken about the way GPs have been spoken about and referred to in both the Assembly and the media over the last few days. I repeat what I said on Monday. This is the first time that a sitting minister in Northern Ireland has chosen to impose the GMS contract on GPs. And to say that GPs across the country are frustrated and angry is a complete understatement. The result of our referendum last week was very clear. 99.6% of the profession who voted rejected the offer, and said it was not enough to keep the lights on and the doors open. There's obviously a huge gulf between our members and the Minister. I would like to address our three major asks as part of the negotiations, but let me be clear, at the end of the day, what we want is to provide a fully accessible service for our patients that meet our patients' needs and wishes. Firstly, our ask was to increase core GMS funding. This is referred to by the Minister during his statement as, I quote, tabling an unachievable demand, money for more of the same, and even a sumptuous 3-course meal, which was particularly insensitive comment. Our ask for 80 million is to stabilise general practice, to keep the lights on, retain and recruit additional staff. This represents 1% of the health budget, which is 8 billion. It was suggested numerous times, both in the media and the Assembly, that this was a blank cheque, which could not be further from the truth. It is to stabilise our service. We can then work from where we are at the minute under intolerable pressure and get to a place where we can employ more GPs, more receptionists, more nurses, so that we are in a place to be able to put a service in place that we're currently at breaking point, and we want to put, this is all about providing a safe service for our patients. Practices have been collapsing around the Minister, and he has chosen to ignore that. With fewer practices, we already deliver, as you know, 200,000 appointments every week. That is 10% of the population. That is set against what Northern Ireland Audit has highlighted as the lowest percentage spend on general practice anywhere in the UK. And we actually reckon that that figure is 2 years old, so we believe actually we've fallen below that figure and are likely closer to 4.7% now compared to where we were then. The Minister has offered 1 million. 1 million, considering we have 2 million patients, that is 50p per patient per year. That's what he's offered us to improve access for our patients. We can only reach the conclusion that general practice is not a priority for our Minister. Secondly, the Minister offered 5 million for indemnity. Again, we heard the Minister refer to it as a toxic discussion and even accusing us of shifting the terms of the deal. We strongly refute that. While we acknowledge the efforts of the Minister as sincere for finally, after about 10 years, giving us a figure to work on indemnity, our position has been that indemnity should be paid to actual costs to doctors rather than split up depending on the number of patients you have in the practice, because that doesn't equate to the number of doctors that's in every practice. It remains unacceptable that indemnity is not being paid to our locum and sessional doctors, and indeed the Minister's remark on Monday, making no apology for this, offended and hurt my sessional colleagues, who I assure you are an essential part of running the service in general practice in Northern Ireland. Thirdly, on national insurance, we remain concerned that the 3.5 million offer may not be enough to mitigate the rise. The Minister's insistence that he said on Monday that we produce the receipts, I'm quoting again, is extremely patronising and unreasonable, as it requires practices to fund the NIC rise before we get any shortfall refunded back to us. The Department have this information. They know how much it costs. They already work out what the superannuation is for our staff, so they, under the same mechanism, they can work out what the NIC is, so they know what it costs us. We sincerely welcome the efforts of the Minister to find mitigating funding for something that has been unfairly imposed by the UK Government, but please do not paint this as additional funding into primary care. The best we can paint this is as cost neutral, but it is not. It's been built up as the 9.5 million as additional funding. It is not any funding we can do anything with. It's a straight in and out. Before I finish, I want to address the commentary on the access to general practice. I fully understand the frustration of patients phoning us surgically repeatedly only to be told there's no appointments. Something we as GPs are desperate to change. It is so frustrating to us that this happens. We produced our safe working guidance to protect patients and staff who work in general practice. This is an attempt to make the Department aware of their abdication of their own responsibility on access. It could no longer be tolerated by us. Members also be aware that we are not asked to publicise our guidance. They asked us not to work to safe working guidance. And one of the Minister's employees asked us to do that. To me, that's mind-blowing. You're telling every other part of the system they can work safely, but GPs, you're not allowed to work safely, and you can't be safe for your patients. The phone-in experience is a symptom of demand in general practice and the lack of investment in core funding to cope with this demand. We've been stressing this crisis for over 15 years. GPs described the Health Committee when the general practice was about to enter a perfect storm in 2015. In February, as part of the contract negotiations and months into the process, the Department asked us to consider a paper on access to general practice, on which the Minister said we only offered to join a working group. We made it very clear we were very happy to work in collaboration with the Department on these proposals to come to an agreed process. The paper was updated with some tweaks at the end of April and was published. It was made clear at that stage that there was no negotiations on it. We weren't allowed to have any negotiations or discussions on it. It is unacceptable during negotiations to put something on the table not only so late in the process, but also as a fait accompli. It would be irresponsible for us as a trade union to agree to something without doing the necessary due diligence and that to the working group. It is premature for the Minister to conclude negotiations as he did. As GPs, we give you our heartfelt assurance that we will keep fighting for our service. We will keep fighting for a safe service for our patients. We will keep fighting to provide more for patients. But to do that, we then have to have more to be able to provide more. Thank you, Committee.
Okay, thank you very much for that. So, I mean, obviously as a member of the Health Committee, my priority is good patient outcomes. From that point of view, I think I'm disappointed that an agreement between yourselves, GP representatives, and the Minister for Health hasn't been reached on this issue. Primary care clearly is the most often first point of contact for our constituents within the health service, and therefore vital to keeping our population healthy. We know, because we have engaged, that GP services are facing significant pressure, which is impacting people's ability to access, first of all, GP service, but it's further putting pressure onto our hospital and ED settings. So this is something that we absolutely need to get right. I would urge the Minister to re-engage with yourselves to bring about a resolution to ensure the population of the North continue to have access to good quality GP services and our communities moving into the future. So we're all, I think, a wee bit shocked and disappointed with what we heard the Minister and the tone of his commentary on Monday. But we actually, this is a really good opportunity to plot how we can move forward and improve that situation. So, Dr. Hagan, you talked, I noted a couple of things you said, and you did say a lot there, but one thing that struck me was you said what you want is a fully accessible, safe service. Mm-hmm. And then you talked, you mentioned your own safe working guidance and some interaction you had with the department in relation to that. I'd like to explore just exactly what you were saying a bit further, because obviously we want fully accessible, safe service. So are you telling me that the department are actually ignoring guidance on safe access for patients?
The department asked me in one of the negotiating meetings, and Kieran's witness to this, asked me not to promote the Safe Working Guidance. Safe Working Guidance is a document that is a UK-wide document, and it's about, you touched on it there when you said there's quality and there's quantity, okay? And quantity doesn't always meet quality, because if you keep working as a GP and keep seeing more patients in any given day, then you are not able to give a patient the time they need. So if one of the best examples is, let's say you have a patient comes in and they're supposedly coming with a sore throat, but that's what they used as the courage to come in, but they actually have something else really worrying them. For example, they found a lump or they're bleeding. And they come in, and if you are in such a rush to get people through, you look at the sore throat and they're hurried out, you miss that opportunity. And if you'd just given them enough time, they would have got the queue in to say, but actually, when I'm here, can I ask you about? And that's probably so much more important. And if you're rushing, you miss those queues. So that's what we mean about safe. it's not just about, yes, quantity is important, of course, providing as many appointments as we possibly can, but they have to be safe. And they also have to be safe for the practitioners providing them, because if you're continuously running to try and keep up, you're going to have GPs burn out. So that's what we mean by safe.
I mean, we obviously all want to improve patient access. I mean, I'm gathering from what you're saying, obviously I don't know who the official was and they're not here either, but I mean, are you saying that they seem to be indicating that rather than have taken the time to indicate with your patient properly, rush through and ignore the safe guidance? Is that essentially what they were saying? Or
well, all I'll say is he asked us to not promote the safe guidance, and I just said back to him, are you telling me you want doctors to work in an unsafe mechanism, an unsafe manner? And he went, no, I don't really mean that, I just don't want you to promote it.
Well, I think we'll all find that pretty shocking, to be honest with you. So I'm going to very quickly ask some sharp questions. Essentially, you're saying there's 1 million extra. I mean, the Minister's talking about 9.5 million, but in terms of funding core services, there's 1 million.
Yeah.
And you need 80 million.
Well, 80 million is 1% of the budget, because if you keep an eye to where we are, we think we've fallen now to just under 5% of the budget. When I first started out as a GP a few years ago, we were operating at about 10% of the budget. And that is, recognised between 10 and 15% of the budget to provide an adequate GP service is what is the recognised figure. So all we're looking is to incrementally work back to that. 80 million is 1%. It's not everything, but at the same time, we have to be able to look at what we can, what additionality we can provide year on year. You're not going to get immediately to the 10% because you just don't have the bodies on the ground to provide it.
And I mean, obviously, we're politicians, we're aware of the constraint in terms of budget. So, we want efficiency within our health service, but we want obviously efficiency with public spend. So, I think it's important for us to know exactly what GPs across the north would do if there was additional funding, and how it would impact patient outcomes.
Well, we would employ more GPs and more reception staff to answer the phone, and hence give you more of an outcome. And I think, Kieran, you have some of the figures.
So, I suppose that some of this is better explained by giving an example in real terms around, practice. So, I've from an average size practice, maybe guts of 8,000 patients. If you get £40 a patient into my practice, that would increase my ability to recruit 1 to 2 GPs with appropriate nursing support, admin support as well. And not only that, it will actually protect the safe working guidance that we're trying to basically to stick to. The real ask from the Minister, even though there's a contradiction in what he says, a lot of the noise in the system is about access, and it frustrates us that we're not able to deliver the access, the demand. The capacity is not there to meet the demand. The only way that can be addressed is that you physically have more people to see the demand and meet the demand. So when you're talking about 80 million, it increases the ability of a practice to increase the staff that they need to meet that demand. And not only, while access is a focus, clearly has become a focus, and we've been aware of this. Again, this is not, there's a bit of a commentary around since COVID. As Frances alluded to in her opening statement, this has gone on for 15 years. Before COVID, there would have been a directive from the old Health and Social Care Board, which is essentially SPPG, around using things like phone triage to try and work more efficiently, to try and identify priorities for seeing patients through the day. This was being promoted long before COVID. So we have been under pressure in terms of meeting the demand for so long now, and the 80 million is really to stabilise, to allow us to have more people to basically provide the mix that we want to provide, which is still a role for phone triage, still face-to-face, routine, urgent, all that. There's such a gambit of options that are there, and the 80 million is to make sure that the people are there to actually start to meet that demand.
And the other thing to be aware of is everybody knows that general practice is the most efficient part of the NHS. We are very light on management because mostly the GPs do the management themselves. And because of that, we can pivot and turn very quickly and change things very quickly. COVID's one of the examples where we were forced to change things. And we are by far and away the most efficient part of the service. And yet we're the ones that we're being told, you can't have any more funding.
So we every week are meeting various sectors within the health service, and often we're having a conversation about workforce issues. So, I mean, if you get the extra money, where does the extra workforce come from? How do you employ extra doctors? Where are they currently at?
So the numbers in training have been increased, and they're up to 121 per year. So that's the number of people come out annually. The problem we have is that to attract those people to come into practices in Northern Ireland is very difficult. A lot of them are what we call, or 50% this year, are international medical graduates, which translates in that most of them are from the south. The last 4 trainees in my practice have all come from the Republic of Ireland, and my current trainee in our practice is living in the Republic of Ireland and travelling to training in our practice and is going back home every night. He does say he would like to work in Northern Ireland, but he says that if it looks like that the locums are going to have to pay extortionate indemnity bills, and that there's no more practices opening up more jobs, then he may be forced to go back down south again. So it's trying to keep these people. There are people there, we just need to keep them.
Okay, and last question for myself. Obviously, relationships between yourself and the Minister and the Department aren't particularly good. My concern is patient outcome. So, I mean, I would be keen to explore what's next from the BMA's point of view.
Well, I think from a point of view of this week, we were just reeling and we're just sort of taking things in, and we've been trying to take stock of what happens from here. From what happens going forward, there's really 2 different levels. The one is on an individual practice level. So individual practices will be sitting down with their accountants in the very near future and working out, can I keep the lights on and the doors open? And those, I'm very fearful for those practices that are sitting who are going to be right on the edge. And then we have an overall thing then as to what the BMA does, and that we'll have to sit down and put our heads together and work out what can we provide with the money that we've got. But remember, the practices that are in crisis, I mean, there's 17 practices engaging with the crisis response team at the minute. There's been over 100 practices gone through the crisis response team since it started. That's a third of practices in Northern Ireland. It's shocking. But the ones that I am much more worried about are the ones who don't put their hand up and engage with the crisis team, don't tell anybody they're in trouble, don't say they're in trouble, don't ask for help, and just hand back. At that stage it's too late, and it's come completely out of the blue.
Okay, and I said it was my last, but you've triggered some. So 17 practices currently in crisis.
Currently with the crisis team.
Crisis team. Well,
there's more in crisis who don't tell the crisis team.
They wouldn't be with the crisis team, I'm assuming, unless they were worried about their future.
Absolutely.
So how many patients roughly would that equate to across the north?
Hard to say, different sizes.
We don't know the size of the practices. We haven't worked out that figure, but like 17 practices, if you're talking, if it was a 17 average size practice, which is like 7,000 patients,
okay,
that's where, it's a significant number.
You're now talking 100,000 across. Okay, thank you. Nuala?
Thank you very much, Francis and Kieran, for coming today, and appreciate that it was quite difficult to listen to that statement on Monday, really to kind of have the rug pulled from under you, really, with no warning. I think there was consensus across the majority of the parties that the tone was not acceptable. The Minister would not address any other workforce, and I think, for example, when he's addressed nurses in the chamber, would never have spoken in that tone or that way. So appreciate that it has been difficult for GPs. There's a couple of practical questions I want to ask that the public might not be aware of, because they are mostly concerned about access. So I think it's important that we do explore all the issues. And the indemnity is not covering locums, not covering sessional. What's a sessional GP for those of us who don't know?
Right, so you have the GPs in the practice who are the partners, so they are running the business as such, but not every GP wants to be a partner, but still some GPs want to work consistently only in one practice, so there's an ability for the doctors who are partners to employ a GP at a set rate, so they'll know what they're taking home every month, and they have a role within the practice. They see patients just like the partners and all the rest of it, but they're not involved in the business management end of it. So they know what they're taking home every month. Staff know what they're taking home every month. GPs have to pay everything, light, heat, cleaning, phones, rent rates, all that has to be paid every month, and your staff, which is your biggest outgoing. And if you have a lot of GPs who are salaried, then your staff costs are bigger. And then what happens is at the end of the month, then the GPs who are partners look at what's left and divvy up what's left. So we as partners have no idea what we're getting from month to month. So it's a business, just like any other business. If they had to pay their costs, and then the owners take home whatever's left at the end of the month.
And it sounds like this issue of GP indemnity and the current offer is creating a hierarchy of GPs within the system. And what's that going to look like with the workforce? And I'm thinking about the junior, more junior medical students who are now training to be GPs. What's that going to look for the workforce?
Well, I think that was one of the, Frances alluded to it in her opening statement, there's a particularly disappointing aspect of not making any apology for indemnity just for practice, for the partnership, because ultimately, since I've qualified, and certainly before that, the natural career progression for if you were becoming a GP is you do your training, certain amount of hospital training, then you train in general practice, and frequently then when you qualify, you will basically become a locum, and you will see how other practices work, make yourself available, and ultimately then you become more experienced before you would decide to either take up a partnership if it was offered, or a salaried role that Frances was just alluding to as well. So essentially what we do is we need locums to be in the workforce to attract them to be salaried or partners. And ultimately in the rest of the UK, if you're a locum, your indemnity will pretty much be covered, or you'll get a significant portion of it. So to say that you only will cover partners, how will we attract locums then into the workforce, the future partners and salaried doctors that we need, if we were to get money to basically fund to increase the numbers? So when a locum is sitting there thinking, well, I'm training in Northern Ireland, but I won't get any indemnity funding whenever I qualify, and I want to locum here, I'm not going to get any help with my indemnity. In the Republic, I'm going to get significant more remuneration. In the other UK nations, it's the exact same. So the career progression in terms of how the critical aspect of what locums do in our workforce has been completely lost on the minister. He doesn't realise that essentially trainees coming through qualifying inevitably cut their teeth in real practice, usually by being locums, and ultimately they are the partners and the salaried doctors of the future. So what is there to attract them to stay?
Yeah, so it's looking like a possible mass exodus of people who could be the GPs.
There already is, over the last couple of years, there has been.
And not stabilising, it's just removing the foundations
exactly.
now. And there has been talk a lot in the media this week about GP access, like you said, you address some of those points, and just highlight, I know that you have done some media on this, but does a GP only see patients, and is that the only work that you do as a GP, as you sit down and
no,
see patients?
you have, most people class their GP as how many sessions they do face-to-face. So if you're doing face-to-face, my day would start off that on the days I'm in practice, usually about between 7:30 and 8, getting down into the practice, because the phone's open at 8:30. You want to have your bloods checked off, your x-rays checked off as they've come in overnight. So in case there's something in there you need to contact somebody about, then the phones start and you start ringing patients back, and you book patients in as the day goes on, but you book them in according to their need. If you're phoning them, it used to be in the old days, people would have said to us, why is the waiting room not as busy as it used to be before? And what it is in the past, you booked a generic 10-minute appointment. Everybody did book that. But the GP had no clue what you were coming in about. So if you're first a sore throat and, something simple, and that's fine. But then if you hit, and you will, in every single surgery, you're going to get a complex patient. And be that because they're old and they've got a lot of things wrong with them, or a complex mental health crisis, or somebody who's worried about they have, bleeding and need examined, stuff like that. So what happened then was, because they had a generic appointment, that could have taken you 30 minutes. So your next 2 were backed up outside, and that went on as the morning went on. Whereas now we're talking to patients and we're getting a flavour of what they're coming in for. And I'm saying, right, I know I'm going to need 20 minutes for that patient. So I am not going to book anybody else. I'm going to leave that as a 20-minute slot. So in other words, when you come into the waiting room, there's, if I have 4 doctors on, there'll be 4 patients waiting, they'll be taken. When you go out, there'll be another 4 waiting, and they'll be taken again. But if we kept everybody in the waiting room that we saw all day, you wouldn't get into the waiting room and you wouldn't even get into the car park. Because we're turning them over and appointing them at a time that means that they can, be facilitated and they're not sitting waiting and waiting. So we're trying to address the patient's needs by talking to them first.
And obviously doing your lab work, looking at your labs, receiving all your letters, referring on to hospitals, having to fill that in.
Yes, and then that you don't get that all done in your ordinary day because your day stretches. I mean, the doors close at 6, and normally that's you, and you try and get a bit of work done. Have to go home, feed the ones at home, sort out, do all that, and then most people go back online then to do that other work that you don't have time to do, or do it, on a day that they're not seeing patients face to face. So spend a session, if they don't go online, go back into the practice but don't see patients face to face, and do all the forms, all the letters, follow up on stuff that comes from the hospital. The hospital have, this line that we all love to hate is GP too kindly. Well, GP too kindly means that we have to find the patient, ring them, bring them in, talk to them, do whatever it's been asked to do and organise that. So that all has to be done outside your time face to face. So just by measuring us with our face to face time is not a real measure of what we do in the week.
Okay.
Just to come in, the last time you were here and back in January, as part of your paperwork was about the iceberg diagram, and above the water is what were the patients that we see, and then the largest bit, well, not the largest, but a significant portion underneath is all the stuff that Francis is outlining in terms of dealing with results, following up patients, dealing with hospital correspondence. Not only that, this is again, which is difficult about the announcement. Virtually all practices are involved in some sort of training of doctors, whether that be medical students, GP trainees. So there's time that has to be set aside to basically educate, and frequently student experience and junior doctor experience in general practice is excellent because we're keen to make sure that we do try and sell it because we want people to stay. But this is all part of every working day, and certainly we have trainees in our practice at the minute, and they are watching this day in day out, and you can imagine their reaction.
And also you have an MDT and I don't, so it's important to say that you have a supervisory role for the professionals who join us.
It is about your
MDTs.
team members. So you look just the way you would be involved in the training of your trainees and medical students. Then ultimately, when you have a functioning MDT, there has to be frequent conversations about patients and interaction there as well as the management. Your practice manager, your staff, all that has to be incorporated onto each day.
Thank you, and I'm sure others will ask questions about that. Final quick question was just to dispel this argument by the Minister about the one-pager, that the BMA refused to give the one-pager and what they would do. I think it is being used as an excuse to shut down negotiations because it's being one way from their perspective. Can you address that here for us today?
Yeah, well, we met the Minister on a few occasions, but the Minister wasn't at any of the negotiations, and we dealt with it in detail.
Or did you say the Minister wasn't at any of the negotiations?
The negotiating meetings,
yeah,
no. Which is normal enough,
yeah.
But that's all we were addressing in the meetings was what we were going to do with the funding. So, why did he need a one-pager? His colleagues have sat in numerous lengthy meetings with us from last year, looking if you want a one-pager, you can have a one-liner. The one-liner is we want to employ more people and more staff and more GPs to see more patients. It's that simple.
Thank you. Colin?
Thank you, Chair, and thank you for your presentations. I likewise was a bit disturbed at the tone of the presentation from the Minister's statement on Monday, not least because it kind of just felt like then there was a big line drawn under it and that was it, and there wasn't a successful conclusion to the negotiations, and it didn't feel like a good way to leave things. It felt like there was a lot of bad feeling amongst the sector, and I don't think that is much use for our sector if they're feeling like that. a lot of what I would need to ask has already been asked, so there's a couple of things I just want to sort of to tease out. And I suppose one point I want to make is I searched the extensive database of casework that I have, and I never found one person complaining to me that they got seen by a GP. You only ever get complaints by people that say that they aren't seen by a GP, and you talk about the 200,000 interactions per week. And I suppose I feel that was typified by a radio programme that I participated in this week with Nuala, where somebody rang in to complain that it was an absolute disgrace that the health service and GPs, you couldn't get access to GPs whatsoever. It was terrible, it was woeful, and didn't know what was happening to the service. And then whenever the person was asked, well, could they see their GP? Oh, yes, I could. And it seems to be something that is a regular occurrence. People sometimes say that their GP practices are terrible and they can't get access to it. If you ring in, do you get an appointment? Oh, yes, I do. But look, I understand that there are quite a number of people that don't get access, and that is a struggle for them. And it's to those people that I want to say, well, let's try and find out what we can do to try and help those people that can't get access. And I suppose I want to ask you this question is the GP sector, in your view, at its saturation point? Is it at the point where it is at a stage where it has to say, there are now people that we can't see? We do not have the capacity day to day to see everybody that contacts us, so therefore we have to take a decision that we'll see X amount of people, but there's Y amount of people that we can't see. Is that where we are?
That's describing very clearly where we are at the minute. The Y is the people who X are getting seen, and as you say, 200,000, a million in every 5 weeks are getting seen. There are a cohort of patients who aren't getting seen, and let me tell you, that is deeply disturbing to us as a profession. We want to see everybody who wants to see us, but you've described it better even than I described it, that when you get to a point that you have used up all your time in a day, you have used up all your time in a day. And and remember, even when you have used up all your time in a day, you have frequently the situation, late in an afternoon where you can get something that you are never going to say no to. For example, one of the things is a complex palliative care patient. Well, I'm sorry, I'm going to leave everybody sitting in the waiting room and I'm going to go out to somebody who's in pain in palliative care, no matter what time it happens at. So even to say, we're setting safe limits and all the rest of it, there's some things you are just not going to leave. You're never going to leave. A very sick child, you're never going to leave. There's plenty of examples of things, even when we've hit saturation, you're still going to make room in your day to say, a severe mental health crisis or whatever, you are going to make room in your day to do that. But yes, there's a cohort of patients, the Y patients, as you say, that are not getting seen at the minute, and we are very disturbed by that, and we want to change that, and that's why we wanted the extra funding.
That was kind of my next point, was then, would it be fair to say that the extra funding that you were looking for was to provide additional services to be able to see the people that cannot currently get seen? So if somebody is out there and cannot access their GP, it's because there's no appointments left because of the number of GPs and the amount of time, and that the only way that they're going to get seen is if we've got more GPs and more availability to be able to provide them the services.
And that's why we call it core, because that's the core of the practice. That core funding funds those GPs and additional admin around the GPs. The MDT money that was announced, whilst very welcome, was money announced 61 million over 5 or 6 years. But that is to put very skilled professionals in alongside to help us. But that is not a solution for a practice that is struggling, because a practice is struggling doesn't have time at the minute. They don't have time to train, they don't have time to have students. So they're not going to have time to bring new MDT people in under the wing, get them used to the practice, get them used to the patients. And, basically when you start an MDT, you have to, review the patients with the practitioner. Just like if you have a doctor coming in and training, whenever they start, you have to basically go over every patient with them just to ensure that they're safe, they're working correctly, and as well as that, a lot of the time, there's institutional knowledge. Somebody like me who's been around for a while, I'll know most of my patients, I'll know their families, I'll know the history, and I won't have to ask, she's a bit stressed, but I know her mother's sick. And I also know that her daddy passed away last year and she's at home with the children on her own. You know, all this stuff that you know whenever you're around, and continuity of care has been shown to improve health outcomes dramatically if you have continuity and people there to who know the practice, or at least who, if you're new into the practice and not there as long, my door frequently knocks in the day going, Francis, do you know so-and-so? And I'm going, yes. And they're going, I had this and I'm not sure. And I was going, but, you know, and that only comes with time and continuity. And that's the same for people who come in as MDT practitioners as well.
This is a final point, and I don't like to pitch sort of various sectors against each other, but say, for example, you were the Royal College of Surgeons that was here today, and we were having a discussion about the significant waiting times that there are for operations, the waiting lists that there are in Northern Ireland. How much money would you be getting each year to deal with that extra work that you have to do?
I think, was there over 200 million allocated?
215 million. There's a huge sector in our population that can't get access to our GPs because there isn't enough capacity. How much were you offered?
1 million of additional funding.
214 million difference between what's offered to one sector to what's offered to the other. So I don't know how you're ever going to be able to expand. So those people that can't see their GPs, there's no capacity, and you're not really getting any extra money to develop it. So I don't know how we're going to go from here. But thank you for your answers. Thank you, Chair.
I think on that last point, I mean, we're interested in the whole system here. So primary care is one part of that system. So we do want, it's important that there's money there to tackle waiting lists, but we obviously value the fact that if money is invested in primary care, that will have a positive impact on our waiting list, because you will see patients earlier, maybe be able to deal with them in a timelier fashion, that they're not maybe needing to go on a particular waiting list or can go on to it for less time.
And you know, I think Ursula Mason, who was with us the last time, you know, gave the figure that for every £1 invested in primary care, you get £14 back to the economy. And remember as well that those patients who are on those waiting lists, they're all people. They're probably relatives of all of us sitting around this table. But where do they go while they're waiting? They come back to us. And because that's all they can do, because they're getting more unwell, they've got more pain, they're less mobile or whatever, and they come back to us. So that is access as well that we're providing while people are waiting on different interventions in secondary care.
Okay. Alan?
Which one?
Oh, sorry, Alan Chambers.
Thanks, thank you.
Sorry.
Thank you very much,
Apologies.
doctors, for attending this afternoon. It's very useful. But just earlier this week, during his oral statement, the Minister did state that he had asked you for this one-pager, details of just how the £80 million that you were asking for would be spent. And he said that he hadn't received it. Now, the next day on the radio, the BMA implied that documents had been shared with the Department of Health officials, and I think you repeated that earlier there. But that's something I understand they're firmly refuting that. Now, I'm not going to get into the business of who's right and who's wrong, but I think it would be useful if you could perhaps share that submission with the committee at some point, and tell us who the officials were that you give it to, and when you give it to them, and that will allow us to clarify just exactly, clear that point up, because it's a point of dispute at the moment between yourselves and the Minister. So I think it'd be useful to get that cleared up. The other thing is the indemnity. The BMA are telling us, I think over the years, it's £12 million a year for indemnity. The department or the Minister was saying that they had checked out, the department had checked out the details through their own services and also with the insurance companies, and this figure of 5 million had come up. So there's a big difference between the 5 million and the 12 million, obviously. But how did you, the BMA, arrive at that 12 million? I mean, were you as rigorous in assembling that information, or is it best guesstimate? And the other thing was the national insurance, which is a burden on a lot of businesses at the moment. A lot of people really going to struggle with it. But the Minister did say that he would give £3.5 million to the general practice to cover that. But he then went on to say, I think, that if it was more than that, his department, he gave you a guarantee that his department would meet. So it wasn't going to cost you any more. You weren't going to be out of pocket anymore. So do you feel that that was a reasonable assurance, and do you accept that assurance from the Minister that he will make up, if it's more than £3.5 million that he's given you, that his department will make it up? Do you accept that? And the other thing about locums, we're talking about locums. I'm just wondering, what percentage of the pool of GPs in Northern Ireland at the moment are operating as locums? Is it a large number or a very, very small cohort of people? Because my understanding is that a locum it's quite lucrative, maybe more lucrative than having your own practice, and that you're guaranteed a sum of money to come and work for a certain number of hours and so forth. So could you maybe share with me, if you have that, maybe you don't have that information, and what percentage of doctors are operating as locums at the moment?
Well, I'll try and do several questions there, do it in reverse. So the number of locums varies because obviously a cohort of people who are fit to locum come out every August or February. So the numbers go up and then the numbers go down when people get jobs or move elsewhere. But it can be anything up to 15% of the GP.
Would there be people who would make a career out of being a locum?
There are some people who, yes, would make a career, and that can be a lifestyle choice, because as a locum then obviously you can pick and choose the days you want to work, and maybe some people might have that for family reasons or caring reasons or whatever, but that's their decision. Some people who are locums work solely in the out of hours, so some people make that as a career decision. Some people who are locum but also do some work in hospitals. So, have what we call a portfolio career, do more than one job, which, can keep people's interest, and they can also bring them what they get in the other job back into whatever practice they're in. But the numbers are fluctuant, but it sits around 15%.
Would it represent an inequality of if, somebody who's made a career out of being a locum and their annual income is more than a practice GP, would it be an inequality that the department would pay their indemnity in full? Would that be fair?
Well, there's very few locums who are earning the figures you're talking about. I think you're talking about the figures that were paid by the trust practices. So what happens, an ordinary locum, if come to my practice, earn a fraction of what you're talking about in the trust practices. The trust-run practices, they are practices that have collapsed. They're not viable, so the trusts go in and they just send in bills to the department. They're not tied to living within a budget. We in every other practice are tied to living within our budget. We can't go 1p into the red, but they just pay exorbitant amounts of money for locums. And you're right, it is much higher than any GP in their own job will ever get to earn. But let me be very clear, we have been adamant that is not what is going to help or save general practice. And those few locums working in those few practices are making hay while the sun shines. But it is not reflective of the vast majority of locums or the vast majority of people working in practice.
Do you think it's fair that those people would have their indemnity paid with public funds?
But no, those people who are working in trust practices, do you get their indemnity paid?
That's automatic. So they will have Crown indemnity because they're under the trust. But I think the important point in that is that two-tier system has essentially been created by practice collapse. So in essence, a trust has been parachuted and they say, we need to keep this practice open. And they will say, well, what are we going to have to pay here to get people through the door? So it's the collapse that has triggered the exorbitant fees. But ultimately, because they're working for a trust, their indemnity will be covered regardless.
So they have their cake and eat it.
And national insurance, do you feel that the guarantee the Minister gave, do you feel it was reasonable, and do you accept it?
Yes, I do, and I do accept it. The only problem is that we have to pay it out and then demonstrate that what we get back in is not enough. So it would be what the delay is, because we have to foot that until any shortfall would then be forthcoming. And all I can hope for is that if there is a shortfall, that it will be forthcoming very quickly and not leave practices out of pocket for a very long time.
I think that's a reasonable request. Okay. Oh, well, go back to my first question there about the statement that you made on the radio.
Yeah,
that you had supplied that.
Yeah, I think I've already addressed
that. Can you supply that to you? I mean, I would imagine it'd be in the form of like a business case, would it? Or
no, it's part of the minutes of all the meetings.
Right. Okay. So if you could maybe let share that with the committee,
I would have to check whether the
minutes of the meetings. Essentially, this has been the
negotiation
culmination of all the negotiations in terms of the minutes, and the minister wasn't at any of the negotiations. Ultimately, what we've just spelled out in terms of what 80 million will get you in terms of increased capacity, it was that simple. That was the simple ask all the way through the negotiations.
But no detail.
The detail is just what I've outlined in terms of the increased GP numbers, increased nursing numbers, increasing staff in the practice to increase your capacity by up to 20%.
Would you build in figures for each of those categories in that submission?
Well, I outlined that at the start.
Just start with 80 million and,
No. Well, the 80 million is the 1% of the budget. So when Francis talked about earlier in terms of moving to a 10 to 15% allocation of the budget for stable primary care, and we're at 5.4, then we need to generate 1%. We need to be getting closer to the 10% to actually bolster the capacity to meet the demand, because as we've outlined already, we're not meeting the demand. So therefore, the only way you can meet the demand is increase the capacity. The only way to increase the capacity is to increase staff, and that's about funding.
Yeah.
Okay, thank you, Alan. Danny?
Thank you, Chair. Just to follow on from what Alan was saying there, obviously there had been ongoing negotiations here, and the detail of those negotiations would have been recorded in the minutes.
Yeah.
The department will have all that already.
Yes.
So I suppose it's up to the
But he
department.
don't have it, Danny.
We can ask
We
the
could get it from the department. We could request it.
Yeah, well, that's fine. Let's do that.
Crayons as well for a one-pager.
Can I just say, I recognise, Francis, your description of local GPs, that knowledge, the knowledge of a family's, full history, medical history. My GP in Larne have looked after our children, for 18 years. They know our family inside out, and the care that we get because of that is phenomenal. I recognise the pressures under them. I've been contacted by local GPs since earlier this week, obviously distraught, and hearing the tone of the argument, which has been mentioned, the tone of the statement, which has been mentioned again and again here. One of the local GPs described it as Trumpian negotiations, and I find that hard to argue with, to be honest, and it did resonate with me. There is an inherent contradiction here that without GP practices being sustainable, accessibility will not improve. It will in fact worsen, likely worsen. And it also seems to conflict with the minister's stated intention to shift left. Now, he talks about this all the time, and shifting left means moving services into primary care and into community care. But in order to do that, they need to be sustainable. If those services aren't sustainable first, there is no shift left. Shift left is not possible. You're not allowing it to happen. So that is something that I find there's a huge conflict there between what the minister says and what he's doing. So I think that needs to be sorted out with him. The contracts, the handbags, is something that the minister was asked about during question time on Tuesday by my colleague Andrew McMurray, and he asked the minister just for the numbers of contract handbags and the numbers that were in special measures. And I know you had mentioned the numbers that were in crisis support today. So we've heard that 17 practices across Northern Ireland are currently in crisis support.
They're in the crisis team, yeah.
Yeah.
And
But the handbags, the number of handbags, so
the minister came back.
What did he say?
The minister came back with the numbers. So he was asked how many contracts have been handed back, and he said, regrettably, there have been 16 handbags since the financial year 23-24, with 11 handbags in 24-25, and in 24-25 one contract was removed. So 16 in 23-24, 11 in 24-25. We know that 17 are in crisis support at the minute. That's hugely concerning.
Yeah. So it's 16 in total over the 2 years, 11 of which were in the last financial year. So you can see how it's ramping up. And we already have one handbag there a couple of weeks ago in South Armagh.
We also know that 17 are in crisis support
Yes.
as well. The question is, you'd mentioned trust-run practices that result from these collapsed practices. How many trust-run practices are there at the minute?
There is 2 in the southern area.
And there's 7 in the west.
9 in total.
I think, yeah, it's just off the top of my head. I would need to double check that, but yeah.
Southern and West.
And sorry.
That's just Southern and West, and it doesn't.
No, yeah, so 9 in total, but in 2 trusts.
There
In two
only are
trusts.
2 trusts that are.
It's only the
South
two
and the
trusts
West
that
are
are
always the
using it.
hardest hit because of rurality.
Yeah.
And not having a border on the other side of it, to pick up, and right along the border area, Fermanagh has been really badly hit, and South Armagh has as well.
The rurality is about recruitment of GPs, and then obviously in these practices, when you've been unable to recruit new GPs because of the rurality and the age of the GPs that were there for so long, then you're unable to recruit again, and the contracts are handed back.
We had a similar situation in my area in East Antrim a couple of years ago as well. My question is, how much does this cost? If the trusts are stepping in to take over practices, how much does that cost compared to a typical GP practice?
We would love to know. We've asked the question several times, and the answer has been fudged. But what the last time we were here, I think Margaret O'Brien was here after us, and she was asked the same question, and the answer that was given was that it's just done on invoice based, so the trust just invoice, but that money is coming out of our general practice budget. But the invoices, if you look at the costs of the locums in those practices, those invoices are huge. Those practices failed before because they couldn't make a financial go of it. So instead of running with the budget that the previous GPs had to run with, and it's an unlimited budget.
Okay.
But that's coming out of our pockets, because that comes out of the GMS budget.
So, Danny, sorry to interrupt. I just want clarification on that. So there's an overall budget for yourselves, and if a practice is handed back, then the money that the trust uses to sustain that practice, which in all likelihood is more, comes out of your budget. So it's an inefficient. I mean, it would be much more efficient to actually invest more in primary care in the first place. Okay, thank you. Just wanted clarity on that.
Which is exactly where I was going.
Sorry, apologies, Alan. Sorry, you should have nudged me. Sorry.
No problem. There seems to be a very illogical step there when you have trust-run practices that appear, we don't know how much they cost, but they appear to be being cost by invoice, and perhaps that's something that we can ask for those figures to find out, how much it actually costs.
Well, the question to ask is, how much does it cost in any of those practices versus what the previous budget was for those practices, and I think that's the figure we need.
No, and I think we should see that. As a committee, we should be able to see that. We've heard that GP practices get around 5.4% of the health budget of over 8 billion. You've now said that you think it's actually lower than that, 4.7%. I know the Minister disputes these figures. Was it 4.7, I think you said earlier?
We estimate it's that is an estimate, but we do know, if you look at what has gone to other areas or sectors and what has come to us over the 2 years since the Audit Office did their figures, we are definitely falling lower.
But the last official figure, you're correct, is the Audit Office is 5.4.
Which is 2 year old, that figure.
And the Minister disputes these figures. I'm not entirely sure why. He hasn't explained that. Can you shed any light on that?
I wouldn't dispute the Audit Office figures.
And particularly on the back of when we were last in front of yourselves, we then had to go to the Public Accounts Committee specifically on the back of the Audit Office report, and in terms of, if 5.4% of the budget gets you the access currently, what would need to happen then to improve that, which is what we're talking about here. So those figures were used and seemed to be reasonable in the Public Accounts Committee. So these are stats. And I agree with you in terms of, if they're going to be challenged, it needs to be clear why they're being challenged.
I think we should maybe write to the Minister and ask him, what his dispute with those figures is, because he was asked about it in question time, and it's something that he did say. And sorry, just one other thing. Just wanted to ask you just about the impact of waiting lists. We have had waiting lists again and again coming up. How much of your workload is because of waiting lists?
It's difficult to quantify, but it is a sizable chunk. Because of the length of time people are on the waiting list, they do get they do get more sick while they're waiting, and they come back to us and come back to us, and it's difficult to actually, you know, work out, but it's certainly every single session that you do, there's somebody comes in who's on a waiting list and with more symptoms while they wait.
I suppose, and to come on, Francis is right, it's difficult to quantify, but a lot of our work in terms of what we do whenever we see a patient, you'll code it as to what kind of an event it was, you know, and their illness to make a diagnosis. But we have practices we have tried, you know, individually to code when somebody has been in front of you with a problem that is because they're on a waiting list, i.e. if you have, say, somebody who's been waiting 4 years for a hip replacement and they're in front of you because they are at their wit's end with pain, you know, as well as coding the fact that they're in with their hip arthritis, you would code on a waiting list. And anecdotally, with some of the individual figures that have been done, it could be up to 20% of your consultations, you know, basically could be because somebody is on a waiting list, they aren't getting sorted, and they've come back to our door to basically to get treatment.
So because we have the highest waiting lists in the UK, GP practices in Northern Ireland are being impacted by that.
Oh, yeah.
And again, you're getting 5.4% of the health budget, or even less, whereas the rest of the UK are getting between 8 and 10.
Yeah, it's variable, yeah.
There's a huge disparity here. You're being
And their
impacted.
waiting lists aren't nearly as bad.
Yeah.
And there will be GPs watching this probably and saying, I would be fortunate to have 20%, that they would maybe be dealing with more than that of their consultations, who are patients who have been chronically waiting on waiting lists. And that's actually to the detriment of patients then with new onset problems that aren't getting seen.
Depends on your patient population.
Yeah, exactly.
You know, you could sit in the university practice, for example, and have most of your patients young, fit, and healthy, or you could sit in a practice where you have a disproportionate amount of elderly patients. You know, there's going to be swings and roundabouts there. You know, just depending on the breakup of your practice.
One last question. The threat of a practice collapsing is very real, and I know people who would live or people who are in that practice would be very concerned to hear that their own practice may be struggling. Other practices in the area then would be impacted by a practice collapse.
Absolutely.
How does that play out?
Well, what happens is that if your GP's gone, you know, you're then going to at best be replaced by sets of locums coming in, you know, to run your practice. Patients will automatically and it's historical where you go. So I could be in one practice, and my husband or your spouse could be in another practice. So if that practice is still open and mine closes, what's your natural instinct to do? Go and try and get on that list. So that puts more pressure on the lists around you. Now, when a practice closes, normally the immediate practices around it are told that the lists are temporarily closed, but that can't go on forever, you know, and it puts huge problems on the practices around it, many of which are often in trouble themselves.
Thank you very much for that.
Thanks very much. Diane?
Thank you, Chair, and thank you for coming again to see us. I think, like everybody in this committee, and certainly I think the tone across the House when the Health Committee or the Health Minister was making this statement was one, we were really surprised and incredulous that the Minister would make a statement in the tone that this one. And I've read it actually and have it with me again today, because I was actually quite, and I kind of said, this is not the way to make an agreement with people, and I think the Minister will come to regret this. I definitely think he will. And as the Chair said, in the interest of patients, we need to resolve these issues. So it is about the patients, it's about the people that really matter who are in pain and so on. And I mean, I do think the Minister strikes a note, because as a constituency MLA, we do get, and Francis, you and I have had this conversation, we do get people saying, I can't get in to see my GP, or one lady was in the other day, she said, I was 70th on the call list, etc., etc. So there people are frustrated by this. I know GPs are frustrated by this, and I was talking to a GP last night at after 10 o'clock and they were still doing paperwork. So thank you for all you do in that sense. That is really important. Again, like Danny, I'm really struggling to understand how, if we proceed with health reform as the Minister outlines and along with his vision, why fighting with and picking a fight with GPs is a sensible option, given that actually to keep people out of emergency departments, we need GPs working at their optimum and being sustainable. So, I mean, I think like everybody, we're just a bit at sea with why this was done in the way it was done. Can I just ask a couple of questions just about this, and then I do want to ask another question. I mean, the minister's, and I'm going to read this from the statement. He says, giving the GPs another 80 million to do what they are doing, with a vague promise they will sit down to discuss the severe access issue, is not an option I can contemplate. Now, you're telling me that your negotiations were about access. So, I think in the way, is there, for example, a plan for GPs going forward that will look at the issues of sustainability, the issues of access? Is that what you've been working on? Is that what the negotiations were about?
That's what we thought we were working on. But the negotiations were unilaterally terminated on one side. I got a phone call on Monday morning and the conversation started out with the negotiations are over. So I agree with you.
So did you, sorry to interrupt, Francis, just to be absolutely clear, you on Friday at 5 o'clock were still negotiating with the minister. You got a phone call on Monday morning and we were called to the chamber on Monday morning and you were told, sorry, it's done.
Yes.
Wow. Okay.
And we also had, of interest, we had a good meeting with the new Permanent Secretary, which had been in our diaries before that. That was Tuesday. And he set out his vision for bringing care closer to the community and closer to the patient,
yes,
which actually we 100% agree with and makes sense. But the point we made was, how are you going to do that if you don't have any GPs? Because he sees GPs as the people leading that. And bringing, all sorts of specialists out to the community, wrapped around the GPs to have neighbourhood care. Which, as I say, the idea is excellent. We know it works elsewhere. We would be supportive of that, but not if there's no GPs to actually be there to enact this.
I think in the as you say, the phone call on the decision on Monday then, and to go to the floor about the announcement, this was on the back obviously of our referendum, because we went to the profession to ask them, and then that vote came through, and then very quick, and we thought that gave us an opportunity to continue to maintain negotiating as to what next steps would be, but it was then the very clear call.
And I haven't listened back to the speech. I listened to it at the time, but I'm afraid I couldn't listen back to it because it was very, very hurtful at the time.
Well, no, I've had several emails. I've had conversations with some of my local GPs who have indicated really that they were so surprised that the health minister would choose to do this in this particular way. And I'm kind of, I think we were all a little bit taken by surprise by the tone of the statement on Monday. So just to go back to the statement, and just to be absolutely clear, he says in the statement that his contract proposals included a number of small but significant changes to improve patients' experience of accessing service. And he goes on to outline some of them, which are, I'm presuming they're not really that fundamental. They're tinkering at the edges with it.
17 of them in total.
And yet he says,
proposals.
Yet instead of agreeing to these, the BMA offered only to join a new working group to consider them.
Working group that his department officials asked us to join, and we agreed to join.
So do you think there could be a resolution to this issue?
As I said to the Minister on Monday morning in our very short conversation, that my door is still open.
And then he asks you to share with your members the latest proposals to address the access issues. But he says he got no assurance that you would forward that paper.
So the paper was a discussion paper. we hadn't had the opportunity to work our way through it. That's what we were going to do in the working group, work our way through it step by step and agree with the department things that we could implement. So we never in the past ever shared a paper that is only just a proposal that hasn't actually been agreed. That wouldn't be normal. So we didn't share it, but then the minister officials shared it with every practice before the referendum.
I don't think butting heads will resolve this issue. I do think the minister and the BMA will have to go back to the table. Yeah. But what I would really like, and I think most people would like to see in the long term, because I do think GPs are fundamental to the way we provide health for the future, that, you know, knowing your GP, my GP practice is the practice that, like, all those years ago I was born into, like, sort of in a way that my mother and father went to. So, like, you know, they know me and I know them. And I think that I'd like to see that we go back to the drawing board and back to the table to resolve these issues, because if we are to have a health service going forward that keeps people out of hospital, that deals with the waiting lists, we will fundamentally have to work with GPs in order to do that, and we will have to value the services that they provide. So I do think that's important. Can I just ask one last question? Because again, there's been a lot of talk around this, and I do know that the Public Accounts Committee are doing the inquiry into the access to GPs, and when they put out a call for evidence, they got a huge response to that. I mean, I think thousands of respondents within a few days. So it is an issue. It is an issue that people want to resolve. Do you think that any plan going forward for GPs, and I do think there should be a proper vision that really values the role that you play, but also sets out that role for the future, do you think that that should also include things like targets and performance assessments, and just to get your sense of what you think that how effective you think the Care Quality Commission inspection and regulations of GPs and GB is compared to what we have here?
I'd like to thank you for describing what is the greatest privilege to be a GP, and I believe to be the best job in healthcare. That's just my personal opinion, because you've described that walk with patients. Patients let us into their lives from the cradle to the grave. Yeah. And it is such a privilege. It really is. And then by that, patients know their GP. So if you go to the hospital, you may see a consultant once or twice or even three times. But you know your GP. You don't necessarily know the consultants, when they're walking up and down the street. But when I'm walking up the street in Armagh, patients know who I am, and that's why I think patients are so distraught about not getting to see their GP. Yeah. And it makes us equally as distraught. I mean, we're doing our best to provide the service we can, and yet, we are getting the criticism that we should be doing more, and we want to do more, but to do more we need more.
To address your quality question then as well, the SPPG regularly have data drops from practices in terms of their consultations, how you're performing, even stuff that was in the previous contract around quality and outcomes framework. These were basically figures around the care you're providing in various chronic disease. That is still counted in every practice. SPPG will engage with practices about these figures on a regular basis. That's standard, and that hasn't changed. There has been some negativity around the Care Commission So, again, it's about the fairness of how they go into a practice, where a practice might be struggling and where a practice is maybe well staffed, and that's the reality of where we are here. You will have practices where we've just alluded to 17 practices that are utilising a crisis team. You imagine a Care Commission group to go in then and assess that practice. That's not going to go well. So it has to be a supportive environment in terms of practices that need the help. but it comes down to the core issue around core funding. And if it's not there, and if you have a department that is not supportive of the underlying GP model, then it's going to be tricky then to try and get those practices back to a level where it's functioning and providing not only the quantity and the access that we're not meeting at the minute, but the quality that you're talking about as well.
And the other thing as well is we are very much micromanaged because we have probity visits. It goes in a cycle, so at least once every 3 years. And they come to the probity visit and they go through the patient's notes of things you have claimed. So you have your core funding, and then the rest of your income is through additional things like vaccines, like smears, minor surgery, all the rest of it. They come and they go through them with a fine-tooth comb to see have what you claimed is appropriate. And one of our colleagues on the next team actually had his probity visit there a month ago, and it went down as far as that they are taking money back for him because they believed he claimed one extra flu vaccine. That's the level we're micromanaged.
Can I say thank you? I do hope that we resolve this, because I don't think it's good for patients. It's certainly not good for GPs. But also I don't think it helps us to get a plan for the health service for Northern Ireland going forward, where we can deal with the really significant issues that we need to deal with.
Well, our door's open, and the Minister knows that.
Thank you. Linda?
Thank you. And a lot of what I was going to ask has been covered, particularly around that 80 million and the Minister's understanding of the breakdown of where it is to go. And for me, I just want to clarify. So the Minister is aware, or the Department is aware, obviously you can't speak for what the Minister knows or doesn't know, to be fair, but the Department is certainly aware of what that breakdown would look like, where you want it to go and how you want it to impact. So it actually casts, I'm going to say, a shadow rather than doubt around some of the stuff in the statement, but then to say that you're asking for additional money to not improve access seems like just a
Contradiction. Yeah.
I'm going to let that hang, just to be honest with you. I think you have already cleared that up for us. You've also addressed the concern around GPs being trained and our ability then to keep them here if we don't have places for them to go. My biggest concern is the patient's outcomes, and you've actually just addressed that, Kieran. So that is something that is actually one of the things that are audited, for a better word, but that is one of the things that are audited. We are currently doing, as you may be aware, the Health Committee are currently undergoing a palliative care inquiry.
Yeah.
And I mean, anecdotally, it's something that I have found just in my own work and people around me. But it was said to us by, I think it might have been the Southern Area Hospice evidence session, that there are many more younger people coming into the hospice or needing palliative care of some description due to late diagnosis, and very late diagnosis, so too late, just to be, I suppose, to be frank about it. Is there any research? Do you know, has that been looked at by the Public Accounts Committee? It probably isn't specifically, but are you aware of any research happening in that sphere to try and drill down to see why this late diagnosis? Because we can all have ideas about it, and I have ideas. I've been saying this now for a few years, to be honest with you, because I could just see it around me. If you have eyes and ears, you can see it and hear it. But are you aware of any research that's happening to try and find out why that is happening? So at what point is it happening? Is it because people are not contacting their GP, they're not getting access, they're not getting the time, as you outlined, Francis, that you're not getting the time for them to be able to say, well, actually, here's what's wrong with me. So I'm just wondering, are you aware of any research that's happening in that
I don't
sphere?
know if there's any research happening, but certainly we know it's the sort of things that keep us awake at night, because these are our patients. We know these people, and when somebody, a young person, or any person, gets a very late diagnosis, it's heartbreaking. and you have to then walk through them, the palliative care, because over 90% of palliative care is done by GPs. So that's really, really difficult. But we do know that if we as GPs had better access to diagnostics earlier, rather than saying, I'm referring you to the hospital to go on a waiting list for a consultant to see them and go, you need a scan. Whereas if we could get those scans earlier, I mean, there are 2 initiatives in the southern area, and if we could broaden them out and make them more widely available. So in Daisy Hill, if I have somebody who I am worried about their chest and think they might have a tumour in their chest, for whatever reason, for the history, I can refer them directly as a GP for a low dose CT scan of their chest, and that will tell me whether they have a tumour or not. And that's a very rapid service. It's great, and it turns around within a couple of weeks. And we then can refer, if instead of referring to the consultant to say, I'm worried about this patient, could you scan the chest? And then they wait on that, and then they wait on the scan, and then they come back to the consultant. We've cut out 3 stages there. So if they have something, we can go straight to the consultant. And the other thing that we have in South Tyrone is it's a pilot where we have it's called the vague symptom pathway, and it's run by 2 GPs in South Tyrone, and it's usually abdominal symptoms, because you're sitting looking at a patient and you're going, is this stomach, is this bowel, is this gynae, is this, I know there's something wrong, in there, but I don't know. So we can send them for a CT chest, abdomen, pelvis, providing we have done, there's some stuff, some routine bloods and stuff you've done first to see if you can work out what it is. If you can't work out what it is, but you really have a feeling something's not right here, we can send them, and they'll get, it's like a one-stop, they'll get their CT scan that day and the result given by the GPs that run it. And then those GPs, if they do have a suspicious lesion in there, then they can send them to the right ology as such for them to be seen. So there are ways out there that we could, if GPs could get access to quicker diagnostics, we would be able to hopefully pick up things sooner. Mm-hmm. And I mean, you're in the west, so that's only my experience in the south.
It's the same to add what Francis said. And again, this is another thing that maybe a lot of people are not aware of. What would be our core day or our core week is every doctor has to be appraised every year. Ultimately, you need to accumulate evidence that you're continuing your professional learning, that you're reflecting on your practice. And one of the key things that would be asked for an appraisal is reflecting on significant diagnosis. So these are patients who maybe have had a diagnosis of cancer, patients who've maybe had a significant mental health event, and what you will do as part of your appraisal is you will reflect on that. You will go through what happened leading up to it, what happened in treatment, and basically subsequently. And whenever you look at all those reflections, it is multifactorial, like Francis is saying. It could be that they've waited too long for a diagnostic, the red flag pathway is too long in a certain area, that they weren't seen quick enough, or it could be that somebody presented quite non-specifically, and that's the vague symptom pathway that Francis is talking about. So again, it's multifactorial in terms of how you decide, basically where there's been a delay in diagnosis, what was the reason. But again, by putting all this reflection, and it comes back to the quality agenda that you were talking about, Dan, that will be reflected on a year-to-year basis. It should be pulled together in terms of where there are very clear trends in certain areas, but it'll be reported in the chamber in terms of what a red flag waiting list is, and say apart. So if a red flag waiting list is 9 weeks, that is not good enough, because ultimately it should be within 2 weeks. That's the standard. So that patient then will have a delay in diagnosis if they have cancer. It's that simple. So if you do that from the point of view of where a patient even decides to turn up to see their GP or an ED, and they've had difficulty with that. So it's from the very, very start to the end, there can be difficulties then in terms of how you delay, what the issue is in terms of delay in diagnosis.
I really appreciate that. Just in relation to the locum stuff, Chair, I think that Francis' suggested question is a really important one. I think if we can also ask the question, and percentage rather than numbers or figures, around the percentage cost of locums in the trust run practices, and they are the practices that had a pick-up where a contract handback happened, in relation to the percentage of what the locum cost was prior to that practice having
what
to do
that
the
practice
contract
budget
handback.
was, what the practice budget was,
And what the
the annual budget.
practice, in the trust fund practice.
So I think it's making, and then maybe an overall assessment of the current locum cost and what the percentage of that is in the GP sector, the GP partner sector, and the locum, and that's percentage, because obviously you have a very different number of practices. I'd just like to get some understanding around that, and we did actually get a figure. I don't have it to hand. I'm going to go back through our papers and see if we can find it. But we did at one point get a figure. It wasn't the overall figure,
Yeah,
but there was a figure to say that there was a significant difference, not to the benefit of anybody, in the cost of a trust-run service and the GP practice itself. And I can't remember the figures. It was a while ago in health committee, but we absolutely definitely got a figure for a. And I think it might have been the one in Portadown, but I'm not 100%. I can't be sure of that, France, to be honest. But it was a significant difference.
We'll follow up on that. Okay, Arlia.
Thank you, and thanks, Francis and Kieran, for all your answers so far. So I think that probably coming out of today's evidence session and out of today's meeting, the most important thing is the point that Diane made around how to actually resolve the situation that we're in, because it's not good for anybody, particularly GPs and particularly your patients. So I'm just trying to figure out then, in terms of like practical next steps, where you can go from here. And I know, Francis, you had mentioned in your opening remarks that you would be of the view that maybe the Minister is actually out of touch with his officials. And I'm just wondering like what that means, why you've come to that conclusion. Is it a case that you think that the officials in the department understand the case that you are making, support the case that you are making, and would be willing and open to continuing those negotiations and those conversations, and that the shutdown is coming directly from the Minister himself? And I just want to unpick that a wee bit to see how we try and move it forward.
What I actually said was that the Minister was out of touch with the profession, with us, because of the ballot that had been taken and then his response to it. He's out of touch with what the profession want.
No, sorry, I picked that up wrong. That's no problem.
As for the relationship between the department officials and the Minister, that's up to the Minister.
Okay, and do you see a way forward maybe, I know that you says obviously your door remains open
Absolutely.
At any point, and I suppose it's, you know, in terms of an immediate next step or outreach, or, you know, are you planning to reach out to the Minister? Are you awaiting maybe the department contacting you? But on the back of this week's statement, where do you think you'll go from here?
The Minister did say that he would put it in writing, his decision, so that was at the brief meeting on Monday morning before he went to the chamber. So we'll await that. But the worry is that in the meantime, in the hiatus, that practices will sit down with their accountants and go, this doesn't work. Mm-hmm. I'm really worried about that. I'm really worried. I do not want another single practice in Northern Ireland to close. Mm-hmm. It's a disaster for patients. It is a disaster for the GPs involved. Mm-hmm. They really, you know, we really get, as you said, Dan, earlier, we know our patients know us. Mm-hmm. There's huge moral injury to a GP to hand a contract back. So it is the last thing in the world they want to do, and it's a disaster for the patients. So I'm worried in the hiatus that people will jump. You know, 16 practices in the last 2 years, of which 11 were in the last year. You know, so that's 5 and then 11. Please God, we don't want any more.
And so that was actually my next question, Francis, in terms of you and yourself and Kieran, your assessment of how immediate do you think that threat of potential, you had said that given the announcement earlier in the week that you don't have enough, some practices don't have enough finances support to keep the lights on or keep their doors opened. So how immediate is that threat, where we could be looking at practices maybe having to shut up shop, and then you're going into then the bigger money potentially with trusts taking over those practices, and then what impact that will have on our already overstretched emergency departments and the wider system?
Well, looking at the time of the year it is, most practices year end is the end of March, okay? So what happens is the accountant comes in at this time of the year and looks back for what was earned from last year and gives you a figure to say, right, your this cost has increased, and then your income has increased or decreased, and here's the difference between last year and the year before, and you can see a trend ongoing. If the costs have gone up too much, and most of your biggest cost is going to be staff, practices will have one of two choices in that case, to say either we cut costs or we close up. And if you cut costs, the easiest way to cut costs is to cut staff, and you cut staff, that cuts access.
Yeah. Well, hopefully those are the points that can be made when maybe the Minister does reach out and writing to us, and just around that urgency of the situation, and that hopefully you can get back around the table and get a resolution. But my last question was just around, it was a point that the Chair touched on at the beginning around, because it actually does really worry me, that issue of not promoting the safe working guidance. And I don't know, I just think it's totally unacceptable that anyone at any level in the health service is advising yourselves as a profession not to apply the HEST standards at all times of safe working. And that just really worries me. And I suppose the question is, so it was a departmental official that had that conversation with you, but the Minister has the overall responsibility, oversight and accountability of our health service as Health Minister, and rightfully so. Is he aware that that conversation took place, and that was, that conversation was actually had between yourselves and a departmental official? Because I just think it's really
I'm not sure
worrying.
whether he is aware or not, but I have said it publicly before this week. I have said it publicly before this week. Around the time that it happened, I said it publicly that it had happened. It's difficult to add to the comment of what you said. Our aim here, I keep going back to our aim here, is we're here for patients. We're here to do more, to try and provide more for patients. And that is our sole aim in this game. This is not about GP pay or anything else. This is about us providing more for our patients, for all of you and all of your families. That's what this is about.
Thank you, Francis and Kieran. Thank you.
All.
Thanks, Chair. In a similar vein to Marlia, I think there was two revelations on here today. One very big one, and that is the safe working piece, which I think it's very important, Chair, that we write to the department and to the departmental negotiators who allegedly said that. And I think the second revelation was that you talked about the transformation fund, of which 61 million is going forth for MDTs. And I think, and forgive me, Francis, if I picked you up wrong, but I don't think you were highlighting that as the silver bullet, as maybe some of us are hoping it would be, to try and ease the pressures within general practice. Is that correct? I know
it'll be a help for practices who are well staffed and well manned and able to supervise those very good professionals that are going to come in with us, and who also have room for, space for those professionals to come in. Yes, it will in time, because as I'll back to Kieran in a minute, because Kieran did develop his MDT and he can tell us about how much time that takes. It's like teaching a student. It's like having, one of the junior doctors who's in training coming into your practice. You have to supervise them. If you are struggling, you don't have time to do that. So the practices that will be helped by an MDT are the practices who are already well off, but the practices who won't be helped are the ones who are struggling.
Yeah, and to add that, we were fortunate enough as one of the first areas that had the MDT rollout. Huge amount of organisation involved in terms of just what Francis is talking about, mentoring the new staff coming into your practice. This is all new. You're talking about having a first contact physio, mental health worker and a social worker that is working within your practice, seeing patients the way we see them. The other thing which hasn't been mentioned so far this meeting is the infrastructure, because a lot of practices, the premises are not fit for purpose. So where on earth would you put an MDT if you magic those three professionals for that practice tomorrow? So the infrastructure, even though there's a a part of the SPPG that is tasked with that, and they're actually coming to our next meeting to go through where their infrastructure targets are, and it will be aligned where they want to roll out MDT next. So that will be another challenge. But the mentoring thing that Francis is talking about is key, because an MDT landing in a practice that is struggling, those MDT members will not stay, they will leave, because they ultimately need to go into a practice where they are mentored and inducted in a proper and a safe way for the patients, and that is critical. The other difficult bit we have with the MDT, if you talk to a practice who doesn't have an MDT, they will tell you it's a failed strategy. And the reason they will tell you it's a failed strategy is there's an inequity in that. I am from a practice that has a fully functional MDT. Francis isn't. 61 million now has been set aside for MDT rollout for another so many federations. At the end of that 5 years, you still will have a group of practices that do not have an MDT. You increase the inequity in terms of the provision, and this is why this is such a fundamental thing in terms of what we've asked for around the core GMS. The core GMS is for all core work, and ultimately if an MDT is absolutely welcome as a strategy, but the rollout has been a catastrophe because it has increased the inequity in terms of provision across the province.
And even the inequity of the MDT that's coming. So I am in one of the groups for this rollout, which is supposed to have started in April. I had absolutely no word yet. Are we getting anybody? Are we not? Or who are we getting? But the issue is that Kieran's practice and the first people in had a practitioner for 5,000 patients, and a whole-time equivalent practitioner for 5,000 patients. Our MDT rollout is getting a whole-time practitioner for 10,000 patients. So there's already a difference there as well.
We call it MDT light.
Yeah.
It's like strummed down. You can see the logic for it in terms of trying to get it rolled out as quickly as possible, but it's not what was initially set out in the strategy.
It's very interesting when you do drill down into the issue of MDTs that there are issues within that certainly I was never aware of. Just another question, Francis. You talked a bit about your daily day and how you start. Just for the benefit of those outside of the GP cohort that may be listening, in terms of members of the public, in terms of your daily day, how many maximum can you see physically in terms of patients, and how does that compare? And it's probably maybe not a fair ask, given that you don't really know the numbers that are trying to access the GP service, because there are large numbers that just can't simply get through.
Yeah. Your day varies because, like that, we operate total triage. Every practice operates slightly different. We operate total triage, so that means we get to talk to the people and then bring them in at a time, A, that suits them, and B, that we know we can give them enough time. So if I have lots and lots of children with sore ears, I can see maybe 4 children with sore ears and a temperature in the time it takes me to see a lady with a complex gynae problem. So it's back to that. It's not just quantity, it's quality. So, and that's why in our practice we structure our day to saying that it's blank to start, because you might have 1 or 2 pre-booked that you've had. Fill that blank sheet with things that are very quick. But equally, you could end up, if I have 3 complex gynae patients, because I do a lot of family planning work and stuff, or if I have, a mental health crisis, or a palliative care patient that I need to go out and see and spend a lot of time with, it might look like I'm not seeing a lot of patients, but I'm actually delivering much better quality to the patients that I have seen. So it's hard to say. Numbers aren't the right judge of it.
Fair enough.
It's time. It's the time you spend, and we rarely get longer than half-hour break at lunchtime, and our practice tries to take that break together so that we can discuss cases and learn from each other. But there's nobody getting out of the practice before the doors close at 6 o'clock, and there's many people there long after.
Can I just ask, and again, this is just something that was sent to me today, has there been a departmental policy to remove self-check-in services at GP surgeries?
No.
Not aware of it, no.
No.
It's just I was sent a photograph from my GP surgery in my own constituency where it says the Department of Health has removed the self-check-in service Should you have an issue about the service, please contact your
Is that-
local MLA.
Is that maybe in the trusts and maybe in the hospitals? Is there a self-check?
No, no.
Not aware of it.
GP
We're not aware of
surgery.
it.
Not aware of that.
And I won't do them a disservice by name.
Okay. Not aware of
Not
it.
aware of it.
No.
Okay.
They have to look into it. Don't
Can I just ask a question just outside of the GP contract? And I'm going to keep this as broad as I possibly can because it's quite sensitive. If a family member of or a constituent was to contact an MLA with regards to the passing of a loved one, and they allege, and I want that in Las Vegas lights, they allege that they feel that it was on the back of failings within a GP surgery. Who investigates that? Because I know, having dealt with something similar back a few years ago, there was a perception by another family that they felt that it was GPs investigating their colleagues.
Right. There is a process.
And apologies for putting you in the spot.
There's a set process. So the first part of the process is to contact the practice, either verbally or in writing, and lay out your problems that you have with the practice. My role as a senior partner in our practice is usually my role to investigate anything like that comes in, and you look at the evidence and the facts, and then you normally go back to the patient. Some things can be sorted out very easily and very quickly. Some of the complaints that come in, some of them are more serious, and you need to sit down and take time with the person. You can either write back to them, offer to speak to them, bring them in, walk them through the circumstances and let them see what happened. And if there's something has happened that was not good within our processes, we should learn from that. Absolutely, learn from that. Now, if a complaint then is not satisfied at practice level, then a complaint then can be taken to the board. And then if it's not satisfied at that level, then a complaint can go as far as the Ombudsman. And within our complaints procedure, every practice is tasked with setting that out to anyone who's complaining, the whole process, right the whole way down the line.
I asked it just because of a very sensitive case that I am dealing with, but secondly, on the back of what you said at the beginning with the safe working piece, which may well fall into some cases that GP practices are being presented with. But Chair, I'll say no more than that. Thank you for that, and we appreciate that. Appreciate everything that you're doing.
Okay, Dr. Hagan, Dr. Mullen, appreciate you coming for us. Obviously, I said at the start to give you an hour, but we give a bit more time. So, thank you very much for taking all our questions.
Thank you.
Thank you so much. Thank you.
Okay, members, so there was a number of issues raised by all of us during that. So, in terms of actions from a committee point of view moving forward, we're going to, I'm seeking agreement that we write to the department to request copies of the minutes from the negotiating meetings and any papers provided to the minister in relation to next steps or options and next steps. That we also write to the department in terms of, I don't mean we're asking or alerting that, and evidence today a departmental official advised BMA not to promote safe guidance, and is that department the minister's position that guidance shouldn't be followed or promoted? And then also the issue of cost. So we're looking to seek clarity on the cost of trust-run practice and how that compares with the cost of the practice's previous budget before they had to be handed back. And then Linda made a point about extrapolating that from a percentage point of view as well. So is everybody happy with that?
Yeah.
So go ahead, Colin, Danny, Dan.
Just the only thing I was going to say, we've got the minister here next week, but it's not listed as one of the things, and I wouldn't want to get to next week and then him say, well, I didn't know you were going to ask me about that, so I'm not going to switch. So would it be possible to maybe just drop a note and say that there may be questions that we might want to ask next week on that issue, just so that it's not blindsiding him and gives him the chance, but at least he'll know that we're going to ask questions about it.
Yeah. Well, if you're talking about, I fully expect he knows we're going to ask about GPs and the contract, and the issue of seeking the cost of trust practice and whatnot all falls within the budget in my purview. So I mean he will have officials listening to this, so absolutely I expect.
Doesn't need to be deep. We just drop a one pager, let them know that we'll be asking the questions next week.
One page. Go ahead, Danny.
Yeah, it's similar to Colin, and certainly those trusts, the two trusts with the trust run practices. Can we make sure we have? Could we ask if we can have those figures for next week? And the other issue that came up was right to the Health Minister question, the explanation of why he disputes the 5.4% of the health budget. Just for an explanation of that, so that we can understand why he disputes those figures. So.
Okay, Dan.
No, I just actually was Colin's point, because I do remember the last time the Minister was here, he got a little bit upset with us because we asked him questions which he said he wasn't there to answer. So I do think actually, it is actually quite important to put it on the record. I think when we're putting that on the record that we are going to ask about GPs, GP contracts, etc., could we also ask him, that he gives us some indication of where he sees the next steps as being, because I think we're all really concerned that we cannot leave it as it is.
Can I ask, Clerk, just how long we have the Minister for next week?
As long as possible.
Indicated that these other appointments, so at the minute it's 2 to 3.
Okay.
1 hour?
That's never going to be enough. Can we go back and ask that we be given an infinite period of time, I think, but certainly longer than an hour? I mean, there are so many important issues within health that I just genuinely don't think an hour is enough. I mean, I could ask questions for an hour, to be honest with you, and so I do think that we certainly could be looking. I mean,
Is the new interim permanent sec coming?
Yeah.
Or is he going to do a separate slot?
Oh, he's coming along with them.
But he's not doing a separate slot?
Originally that was the plan, and it was due to be today, but then the department came back to say, as the Minister was coming next week, that he would want to come with the Minister, and therefore he's coming next week with the Minister. If members then wish to do something further following next week, we can certainly put the request in.
Okay, we'll see how that goes.
But would that be worth decoupling, because that might be not a difficult conversation, but it might be an unusual conversation at the first time that we're meeting the gentlemen we're discussing an issue that we want to interrogate, given that there might be an opportunity to come back and say that they only have an hour with a Minister and a new permanent secretary, and that issue would be quite a heavy agenda item that we mightn't get very far. It may not be fair to him that wants to come in and talk about the work that he wants to do within the department and where he sees things.
We'd like to hear his vision, really.
I don't know if that's...
What we'll do is with the Minister and the Permanent Secretary, I mean, the last time the Minister and the Permanent Secretary here, the Permanent Secretary answered most of the questions, in fairness. So it's important that they're both here next week, but we can then go back and say that we would like a further meeting with the Permanent Secretary on his own.
And just while you're on it, Chair, I'm also going to ask him about the respite allocation funding.
Budget.
Yeah, I know, but last time I asked him a question, he did say, I'm not here to answer that
He
question.
was very upset.
Okay, so...
Just on the letter that we're sending off to the Minister on that session. So Diane was saying about what he's going to do next in terms of with the BMA. I don't know if it's appropriate. Can we ask him the direct question if he's willing to reopen negotiations?
I think he'll be here. We can ask him whatever we want. The Minister will decide whether to answer the questions or not. So okay. I mean, he's the Minister. He knows what's on the health agenda. He knows what we're talking about. He knows the issues of the day. So I mean, I'm not going to stop anybody asking a question. It'll be up to the Minister to decide whether he answers it or not.
Make peace, not war. That should be the theme.
Yep. Okay. So,
Chairman, if the Minister is coming for an hour, or if he decides he'll come for an hour and a half, the time goes very quickly.
It does.
And he has shown in the past he will get up and go at the end of his allotted time. So I think perhaps, and maybe the onus will be on you as a chair, to ensure that you know, that everybody gets an equal chance and an equal amount of time. You know, there'd be no use if 2 or 3 of us are sitting as the minister's going out through the door and we haven't had an opportunity, whereas other people have maybe taken 15 minutes to make statements and eventually get to asking the question. So I think the will require, if we're going to make the best use of it and everybody's going to get an equal chance, I think we're going to have to be very disciplined about how we use that hour and a half.
You'll remember, I think it was my first or second meeting as the chair. The minister was on the last time, and I just basically told you, this is the amount of time you've got, and I think I actually pushed past everybody, so that will be the case depending on how much time we have from the minister.
I appreciate that. Thank you, Chair.
Every member will get the same amount of time, or as close to it as possible. Anyway, moving on. So, yeah. Next item is oral briefing from the Department on Home Care Services. So can I refer members to tab 6? So we have a briefing paper at page 3 of the table papers. And we're now obviously going to have a presentation. So can I welcome Mark McGuckin, Director of Disability and Older People, Dr. Ciara McKillop, Interim Director of Community Care Directorate, Eilish McDaniel, Social Care Reform Director, and Debbie Murray, Head of Home Care Unit. So you're all very welcome. So somebody's going to give a brief opening commentary, and then we're going to ask questions. So
I'll start, Chair. Thank you very much. So thank you to all of you for the opportunity to provide an update on the provision of home care services in Northern Ireland. From the outset, I want to be clear that we are deliberate in our use of that term, home care services rather than domiciliary care services, as we believe that reflects the kind of care that we want to see going forward. And that is good care to support well-being at home in response to a growing volume and greater complexity of need. We noted at previous meetings that we want to see a shift away from the time and task delivery model to a more outcomes-based service that is responsive to meet the needs of individuals. But we can't make changes to how home care is provided in isolation. As noted in the briefing paper, we're working on the development of a 10-year strategic plan for social care reform, adult social care reform, including home care reform, and I'll comment on this more fully later. Home care continues to play a vital role in supporting people with complex social, emotional and physical needs to remain at home. It helps prevent unnecessary hospital admissions and enables timely discharge, ensuring that hospital capacity is used effectively. However, the system remains under considerable pressure, reflective of wider changes across the health and social care sector. Since the Department's last engagement with the Committee, we've progressed a number of strands of work under the Social Care Collaborative Forum, and through the forum we have started to tackle contract and capacity issues, workforce issues, and to consider how we make improvements in terms of the data and intelligence we hold about the sector and how we make use of that data. The forum comprises 8 work streams. Currently, and my colleagues with me here, Ciara and Mark and Debbie, are helping to lead much of that work. I like to think that the forum comprises the leadership envisaged in the Power to People report, that is system leaders who need to work collaboratively to challenge and change the way that things are currently done. Leadership and collaboration are fundamental building blocks of adult social care reform. And the forum comprises leaders from across the department, trusts and the independent sector, that's the community and voluntary sector, and the private sector, collaborating to develop innovative and sustainable change. And we're implementing these changes alongside protecting existing service delivery or early improvements wherever we can. In terms of current service delivery, we continue to see high levels of demand and delivery. On average, in excess of 294,000 contact hours are delivered each week, covering more than 23,000 service users. This is provided in large by the independent sector, who deliver in excess of 74% of that service, with trust staff delivering the remainder. This mixed model of delivery is essential to ensure that the needs of the population are met. And going forward, the reforms will be built on this partnership between statutory and independent providers. We think that it has to be. We're seeing positive increases in contact hours and visits delivered. However, the number of people waiting for a full or part package of care remains too high. And as of March 2025, over 3,200 individuals were waiting. And while this represents a 9% reduction since October 2024, reducing unmet need remains a key focus for the Department and the Social Care Collaborative Forum. Reform is ongoing, and we are seeing some positive examples in individual trust areas. So, for example, the South Eastern Trust has implemented a number of promising changes with co-designed care plans, empowered providers and digital innovations. One major example of this innovation relates to the Care Line Live implementation. And this is a digital solution which has enabled more robust analysis of gaps in provision and resulted in over 4,000 hours being recycled for use elsewhere. This system is now being implemented across all trusts, and we expect similar impact in other areas as rollout progresses. We're determined that where a pilot shows that that's sort of significant impact, we will make the necessary steps to implement a consistent approach across all areas. Early review teams have also proven effective, and they've released an estimated 2,800 care hours per week across 4 trusts. And while recruitment remains a constraint, expansion of this model and further evaluation is planned. From a funding perspective then, the budget for home care services in 24-25 was $383 million. In response to living wage pressures, the Minister approved uplifts to hourly contract rates in both 2024 and 2025, with the minimum now set at $21.35 per hour. The Minister recognised the need to ensure the stability of the home care sector and prioritise this uplift of around 7% at a time when he was facing and continues to face unprecedented funding pressures. The Minister has also made a commitment to make adult social care a real living wage sector, and work is at an advanced stage to provide advice to the Minister on how we will implement this. And I think, Chair, you were at an event this morning where that was discussed. This recognises the importance of the role the sector plays. However, money alone will not deliver the reforms that we need. The Social Care Collaborative Forum has continued to play a key role in shaping the future model of care. Building on the Power to People recommendations, a 10-year strategic plan and an initial 3-year delivery plan are nearing completion. The timeframe reflects the extent of the change required to deliver a truly reformed adult social care system, and also the scale of the challenge it needs to address. The delivery plan will run alongside the Minister's 3-year health and social care plan. The January 2022 reform of adult social care consultation identified 6 strategic priorities, and these have been carried across into the strategic plan as individual choice and control, supporting unpaid carers, prevention and early intervention, the centrality of home, a valued workforce, and finally sustainable system building. For each priority, the strategic plan includes a number of high-level strategic commitments and associated strategic actions. Key strategic commitments in the plan include developing and implementing a digital and assistive technology plan, improving the information, advice and guidance available to unpaid carers, enabling them to more easily access support, exploring ways to make the shift towards neighbourhood-based, preventative, citizen-focused support models, including through the use of social finance, improving existing needs assessment and care planning processes, introducing a package of measures aimed at improving the quality of care in care homes across Northern Ireland, developing strategies for specialist and supported housing, including in relation to clients with more complex needs, implementing the new social care workforce strategy focused on improved pay, improved terms and conditions, career pathways, better supervision and support, and access to greater training and education opportunities, and finally more effective workforce planning. Another commitment is improving systems and processes across all sectors to, among other things, maximise capacity and address unmet need. We'll also introduce a new adult social care legislative framework, a different approach to commissioning, and a sustainable funding model for adult social care and support. And finally, a final commitment is improving data and intelligence about the adult social care and support sector to inform planning and future delivery of services. The aim of the 10-year strategy is to reform how adult social care is delivered and experienced across Northern Ireland, with a focus on adults being independent, having choice and experiencing good quality of care on an equal basis. We want to see greater attention paid to innovation, including through better use of technology, and a strategic shift towards prevention and early intervention. We also want to harness the power of communities and neighbourhoods to support adults who live within them. In summary, what we want to deliver is a truly person-centred and flexible care. Above all, the plan is seeking to deliver a continuum of care with preventative initiatives and community-based support at one end through to residential care at the other. And in between, we want to offer adults a greater range of care and support options, including through self-directed support. And for self-directed support to work better, we accept that the process for accessing it needs to be more streamlined than is currently the case, and the support being sought will also need to be available. And within this approach, home care will be integrated with wider community supports to maximise individual well-being and connection. As reflected in the plan, this goes beyond just agreeing to what's offered. It means individuals having genuine opportunities to weigh different options, express preferences, and make choices about what support they receive, how that support is delivered, and who provides it. It will also empower individuals to decide where they live and to maintain as much control as possible over their daily activities, their social connections, and their personal interests. We've got strong cross-sectoral commitment to the much-needed reform of adult social care. And we trust that by implementing these plans, we will have successfully delivered on the reform of adult social care consultation and the Power to People reports. The plan will include a high-level strategic framework, and a high-level strategic outcomes framework and associated indicators, and we'll use these to monitor whether or not we're being successful. So if I can summarise, Chair, the Department recognises the urgent need to reform and strengthen home care and adult social care more broadly. While progress has been made, including reductions in unmet need in home care and increased use of digital systems to make provision more efficient and effective, the pressure on services remains high. Continued innovation, investment in the workforce, and new delivery approaches will be critical in addressing these challenges and ensuring that home care services and other care and support services remain sustainable and responsive to the needs of people of Northern Ireland into the future. We welcome the Committee's continued engagement and oversight as this work progresses, and as indicated in the paper that was provided in advance of today, we will share the reform strategic plan and the initial 3-year delivery plan with the Committee when it is finalised, and we hope to be able to do that before summer recess. Thank you, Chair and members, and we're happy to take any questions that you have.
Okay, thank you very much. That a lot of detail in that. I should have at the beginning apologised. We kept you slightly longer than suggested. The last issue was obviously a very important issue, and as we all know in this committee, every issue is so important, and this is a very important issue too. And as we also know that within a health system, as I said in the previous session, that when one is kind of out of sync, it has an impact on another part of the health system. So as a constituency MLA, one of the major issues coming to my office is concerned families trying to get appropriate home care packages for their loved ones, and at times that is an issue. And then obviously as a member of the Health Committee and Chair of the Health Committee, I also see the impact of that within the health system in terms of our hospital beds and not having people discharged appropriately. So this is a vital issue in terms of care for those who need it, but also with regard to the bigger health system. So you're right. I was at an event this morning, Living Wage NI organised. Was very good. I wasn't able to stay all particularly long, but long enough to know that one of the, I mean, you've outlined some of the problems and you've said that money isn't the totality of the issue, but certainly workforce is a major issue, and I imagine workforce is a major issue because of pay and work progression and stuff like that. So you did say that the Minister gave a commitment, and I gave a commitment this morning that I would ask just for an update on that living wage for care workers. So you seem to be suggesting that you're at a very advanced stage and with regard to preparing a paper for the Minister. So the Minister will have that paper soon and will be able to make a decision on where we go soon.
Mark, do you want to take that question?
Yeah, Chair. We're working with the Economic Policy Unit in the University of Ulster to do the modelling for us. We've engaged quite extensively with colleagues in England and Wales on this, because Wales were probably the forerunner for the Fair Work Forum that we've set up. So in terms of real living wage, we're looking now to say the real living wage now and the national minimum wage, there's very little difference in them. There's about a 3% differential now between the real living wage and the national minimum wage. So we're looking to see now, in terms of the package we bring forward to Minister, to say, if we only go for the real living wage, this is what the impact we believe you will have. If you go for the real living wage and add-ons around, for example, sick pay or travel time or holiday pay, here's the impact that will have. And largely, that, as I say, that's been modelled on what's happening in Wales, because there was a minimal impact, we've been told, in terms of just doing the real living wage in Wales. So it was the real living wage plus those add-ons made it a much more attractive. And I say, because there's such little difference now between the real living wage and the national minimum wage, we need to make sure that when we're going to the Minister with the package of options, that we can detail to him exactly what we believe the impact of that will be and the outcomes of that will be. So simply saying we move to a real living wage sector probably won't make the impact we thought it would have made when we started this, because I say the differential is so small at the minute. I think the commitment that the Minister has made in terms of the sector will be a commitment going forward that says we will try to keep pace with the real living wage uplifts, because the real living wage, previously the difference between the national living wage and the real living wage was around 10%. So if we can try and keep pace with that going forward, then that will be the commitment that we will ask the Minister to make. He's already made the commitment that he will implement the sector as a real living wage sector, and then going forward trying to keep pace with that will be the second part of that for years to come. Now he's made a commitment this year of around 25 million, because we hope to get this brought in around September, which dovetails with the Western Trust tender for services slightly different than the other areas. So the Western Trust tender, the first lot, the first area, goes live in September. So that's why we'd said the Minister would cost around 25 million this year, and then the recurrent of that would be around 50 million each year. For every pound we put on to the hourly rate, it costs around £11 million to deliver. So we were probably in the ballpark of around an uplift of around £4 to £5 per hour to the regional rate to deliver the national living or the real living wage commitment.
Fair enough. And all of that makes sense. Just kind of slightly different to that in terms of the current pilot, where there's an enhanced rate in rural area. You know, how successful or otherwise? I mean, can you give us a sense of that in terms of how doing its job, getting more staff, retaining staff?
Do you want to take that?
Yeah, I don't. The intention wasn't to get more staff. I think the intention was to make as best use of the staff that they had. So rather than purchasing care on a time and task basis, what they're doing is offering a block contract for a geographical area to a provider, with the efficiency being that, you know, say you're allocated half an hour for a number of tasks. If that doesn't take the full half hour, if the trust and the provider were able to gather up all the leftover minutes, that they would maybe be able to put additional visits in, or additional calls in, or additional travel in. So that they've purchased a block of activity in a geographical area. Now it hasn't been fully evaluated yet, Chair, but the indications are positive. The independent sector have continued the pilot, and the Northern Trust, I mean, it was initially in the Portrush, Port Stewart area, but they're intending to roll it out further because it seems to be working.
And then lastly for me, I mean, the Health Minister has prioritised health inequality. So, I mean, I know in conversations with some of my colleagues, you know, this is an issue, trying to get home care provision in some areas where it's maybe not in others. So can we have some indication of just the extent of regional inequalities?
I mean, it should be available everywhere because it's based on a critical need or an essential need. And I mean, how it's working is that the independent sector are providing areas, and where there is no cover, then the trusts are using their statutory carers to go into those areas. The challenge is, you know, if you have a very isolated farmhouse, for example, where it's a 15-minute drive for a 15-20 minute visit and a 15-minute drive back again, those are the calls that are presenting the real challenges. So those are the ones that I suppose both the Western Trust model of procuring in lots and the Northern Trust's pilot, where they're using block geographical contracts, are trying to address those issues. Okay. Don't think we have full comprehensive solution yet. I suppose there are challenges with both, but the benefits seem to be that we're able to provide more cover to those calls that would have been hard to allocate before that.
But I suppose on the wider point about equality, I mean, there is work ongoing to look at unmet need and where it is and why it is happening and what we need to do to, as you say, Chair, address the gap that exists. So it should be available everywhere where it is actually needed, but that work is ongoing.
Yeah. We've some areas where we've over provision, you know, for example, in some of the city areas, and under provision in some of the rural areas, so we don't have all of the capacity where we need it to be.
Okay. And is there any sense of, come back to my earlier conversation, that, you know, the nature of the resource, either in terms of staff or monetary resource, that will alleviate the system with regard to, you know, discharge from hospitals? I mean, because ultimately, you know, that must be a key priority for the Minister.
So that work is going on. So I think that the committee is probably aware of the work being led by the CMO and CNO around winter pressures, and a number of projects have been established as part of that work. One of them will look at both at admissions to hospital, but also discharges from hospital and why delayed discharges are taking place. We will have some intelligence about why delayed discharges are taking place. I think it will be done more comprehensively as part of that project work.
And will we see improvements this winter?
That's the intention.
Thank you. Nuala?
Thank you, and thank you very much for coming today. It is an important issue. Indeed, at committee we've asked many times about this. One of the positives I think that we're moving away from is what people out there believed used to be like the 15-minute slot that they were given for domiciliary care, and that's it. So I think it's positive that we are moving away from that. So just a supplementary to the previous question regarding the geographical activity. And if they complete their tasks in under 30 minutes, can the same be said if it requires more? So yes. It's going to be all based on need, regardless of what you need. So there isn't going to be a specific time slot. So can we just confirm that is
that's the intention? Mm-hmm. Okay. That's the intention, okay. And it's about how the trusts on the one hand are ensuring that there's still the same quality of care. You know, that carers aren't rushing in to get things done really quickly, so that the same quality of care is maintained. But that if you don't require 30 minutes, and maybe our time's spare, that can be added on to somebody else's visit, and there's no detriment to the provider or to the person who's receiving the service. So. And
I just wanted that confirmed, and forgive me my ignorance if this is obvious, but sometimes it's not whenever we have a huge independent sector, and we do have a huge independent private sector in delivering that care. And can we ensure that any increase is going directly into the pockets of workers on the grounds? Like, is there an assurance that working with the private sector that is going, or is that
as part of this, we've done analysis in terms of what the rates of pay are across the sector. There's quite a few of the main providers already paying real living wage and above it. So, but as part of the uplift, the Minister's clear intention will be that the trusts will contract with people who are prepared to pay real living wage and above. So this will be an iterative process, because we can't have all that done by September, but it will be the clear intention going forward that contractually you will need to pay the real living wage and above to be contracted with the trust to deliver.
And what about miles and mileage? We don't want to see independent businesses saying yes, we'll pay them real living wage, we're actually going to take their mileage off them then. So will we? How do we get those assurances that people will actually be paid mileage?
And that is what we're hearing as well in terms of some of the adverts you'll see on the billboards. We pay £15 an hour, whatever it is, but some of those hidden costs are already in there. So if we're saying to providers, we will pay you £25 an hour, whatever it will be, we will say, and that includes an element for mileage, includes an element for holiday pay or sick pay or whatever the final package is the Minister will approve. But that, again, contractually going forward, we will make sure that is built in where they're delivering those services, that is part of what they have to pay out. To be fair, you know, even if we get to £25-26 an hour, the Home Care Association are saying that they believe the going rate for Northern Ireland should be around £32-33. So we're still well below what the associations believe we should be paying, and
we're starting to catch
up, and we're trying to catch up. Now, I don't think we'll ever get to there because it's probably unaffordable at this stage. But certainly those sort of issues, Nuala, that you've raised are the issues we're having around the Fair Work Forum discussion.
And just a different direction now. With regards to self-directed support, delegated nursing tasks through direct payment and also onto supported living, we have been engaging with a number of trusts around delegated nursing tasks. At the start there was some confusion that it was the department directed policy around the change in delegated nursing tasks, but now through written questions we are finding that actually it's each trust taking on and assessing these issues of delegated nursing tasks. So the trusts have removed the ability of using the direct payments for delegated nursing tasks, but in some instances have said that it was the department. So what's actually happening with delegated nursing tasks, because families are struggling because they're having to do it with themselves because they don't think the trusts are really across. They're saying it's about legal advice, but initially we were told it's department decision. What's actually happening, because it's families that are doing these nursing tasks and they will have all liability, have to suffer every consequence. It's a very unfair system.
So there's work ongoing. I'm involved in it with the Chief Nursing Officer and the Chief Social Work Officer around that. So you've two, at the minute you've two delegation frameworks, one for nursing and one for social work. But there was legal advice, to be fair to the trust, there was legal advice which said in terms of the risk, because when you delegate a nursing task as a nurse, if you delegate it down to somebody, you're still responsible for that if it goes wrong. So there was some issues raised around the risk of that. There's been subsequent legal advice which has changed the first legal advice, okay, and we are now as a department seeking a definitive response from Senior Crown Counsel that we will be able to give the trust going forward. So that there is a bit of confusion around it, to be fair, and there's also then confusion around those tasks can be delivered within, for example, a special school setting, but then when you become an adult it changes. So it's a bit of a confused picture, if I'm honest, Nuala, but we are working through that. As I said, it's under the leadership of Maria and Anya in those two professional offices, but the work is ongoing.
The anticipation at the minute is that there will be, there was never a change in policy, there was just an advice, and then the trusts took from that advice. There was no change in departmental.
There was no change in departmental policy.
Because that is what we were told in our first engagements with all the trusts around. Like there was, I think every MLI had an influx around this issue of delegated nursing tasks, because people were left, yes, they had the money for direct payments, couldn't do anything with it, couldn't get anyone, and then it was up to, you know, parents or children of parents to actually take on that. So I think it's important that there is clarity as soon as possible, but also that it comes from the department to the trust, so that the trusts have to do it.
Well, that is the intention. NIPEC are working with us as well in terms of that those work streams. But as Eilis has said, part of the wider reform is also about making that whole self-directed support much easier to navigate and much easier to roll out, and for people to actually take self-directed support and PAs, etc. So to make that process clear and much more easily navigated.
And to implement it in its widest sense too. I think self-directed support at the minute is associated with direct payments, but there's the option to have a managed budget too, which I don't think is terribly well used. So the intention is to try and promote self-directed support and facilitate it in its widest sense.
My other area was around the supported living, but supported living and residential care, and as you did say at the start, around people having as much control as possible in their daily lives. But yet, if there are residents who moved from Muckamore into supported living. There are residents who moved into residential home, and then now they have there is a different standard in terms of how they're able to actually access living their best in daily lives. And currently there is an assessment, and it's around £30 a week, that if you're living in residential, that's what you get, £30 a week. But if you're in supported living, it is different. Is there going to be any work as to the effect of what that has on individuals? You know, there's some families, for example, who have to pay for the outings of their loved ones, but they also have to pay for the staff to go along with them. Like, they have to pay for their tickets, their entrance fees, anything they want to do. That's very unfair, because these people aren't allowed to just leave their home. You know, they have to be accompanied, but yet families have to purchase and pay for everything, and it does seem a bit unfair. Is there any intention to review that?
There's some work planned around supported living in terms of the regulation of it, if that's what you're getting at. No, I'm not convinced that
it's more residential is where the impact, where it's £30 a week, and supported living, it's more like your entitlement is greater, even though you have people coming in every day as well.
Well, the ethos of supported living is that it's your own home and you have much more control. As Ali says, we're doing work at the minute. At the minute, supported living sort of sits in between home care care home standards and domiciliary care standards, as they're still called. So we're looking now to put it. We have a work stream ongoing, which is co-chaired by Association for Real Change, around looking at what do we actually mean by supported living, what the concept of supported living, or what does that actually mean, how we fund it, how we manage it, how we assess it. So there's a lot of work ongoing between the department and DFC and the housing executive around the whole supported living area. You're right, it's different in a care home than it is in a supported living.
There's no review to that £30 a week allowance?
Sorry?
There will be no review to the £30 a week
We're also doing a review of the care home standards and the regulations on the care home. It's being led by Debbie's team, so again, it's part of this wider programme, so that will be part of that review as well.
Okay. My last question then is the kind of gateway between yourselves and the trusts when it comes to RQIA and implementation of any enforcement action that they have placed on care homes or supported living homes. And I've tabled some questions around this as well. But there are concerns that RQIA has placed enforcement action on some supported living accommodation. I don't want to, they've been in the media, I don't want to name it, we don't need to. But where can the department step in? Some of these places do have residents that have moved from Muckamore in them as well, and now there is issues that amount in RQA have said that amount to isolation, you know, seclusion, and not restraint insofar as physical restraint, but not being able to leave your actual home, which is, as you said, is supposed to be a home. So where's the gateway between the trusts and the department of overseeing that this is going to actually change?
The department sets the legislative and standards frameworks within which the RQIA works, and I'm sure you're aware of that. As Mark has indicated, the intention is to look at all of that as it relates to supported living. So,
do you keep an eye when these things happen? You know, when enforcement action.
We're always informed of
and what's your engagement activity like then after that?
We have the specific instance you're talking about. We're well aware. We've had ongoing engagement with the provider, with the trust, and with RQIA around that particular issue, and again with DFC colleagues and housing executive colleagues. So we are well aware of that issue, and there is regular contact with DFC. We're not RQIA. We're not a gatekeeper as such, because RQIA are obviously the regulator. They will go in and do that inspection. Where it then comes to us is in terms of if improvements need to be made, or we can work with the providers in terms of restraint and seclusion, which is what you've mentioned specifically there. There is ongoing work within the department around the restraint and seclusion guidance and how applicable that is outside hospital settings, because it is largely based around a hospital ward or a hospital setting. So when you go into a supported living setting, that guidance may then not be as black and white, if you like, in that sort of setting. So there is work ongoing within the department around that as well, working with RQI and working with others on that.
Thank you.
Thank you, Diana.
Yeah, no, just very briefly, there's in your table, I think it's on page 10, there's quite a variation in the average length of time of a care package between the trusts. Is there a reason for that?
I think it varies based on the assessed need. All the care packages are based on the assessed need coming out of hospital. Dan, if it's helpful, we publish statistics each year around community care for adults in Northern Ireland, and invariably the majority of visits are between 0 and 15 minutes. Over the 2019 to 2023, that rose from 279,000 to 316,000. Equally, those visits, which lasted between 16 minutes and 30 minutes, rose from 160,000 to 191,000, and those visits, which were 30 minutes plus, rose from 75,000 to 83,000. So there seems to be across the board increases in the level of, or the amount of care being delivered and the time being taken. But I don't think we're aware of anything specific in terms of regional difference in them. It purely is based on the assessed need when someone's coming out of hospital. That is what the package will be delivered.
Alish, you said in your opening remarks, and I could have taken this up wrong, because I think there's a couple of things that I'm keen to see. One is that we move away from the task and finish issue, because I don't think anyone is satisfied that provides an appropriate service for need. And many of us in this room will have had the experience of that with older loved ones. And it's a fairly... I think in the Southern Trust, for example, during the week it works very well, because a lot of the Southern Trust people are actually trust employees, whereas at weekends, when that then became an external provider, it could be anybody and everybody who didn't know that older person, and it was very, very difficult then to have a satisfactory or even the same level of care. So I think it's important to move away from that, so we're not too prescriptive in what we're sort of saying people can do, but that you can address need. Is there an intention? I know this has been done as a pilot in the Northern Trust. Is there an intention to try and drive this forward as the way forward for packages in the future? Yeah, across all trusts, or is there resistance in trusts to that?
If I come back to your original question, Dan, I mean, you're concerned about the variation in the number.
No, look, I don't think concerned. I just was wondering why is that the case? You know, and I'm just wondering, is it some trusts just allocate more time, and some don't? That's really what it was. If it's based on this is the assessed need, that's okay, because we should be basing things on need. But if it's just we have that amount of people and we can do that, then that's not where we need to be.
One of the questions is assessment being undertaken consistently then too. One of the plans is to actually look at how we assess and how the assessment tool is being used across trusts. So there's a commitment in the plan that I've referred to actually undertake a review of how assessments are undertaken, because that in part could explain some of the variations. It could. Yes. It could. I don't know whether it does, but it's a possible explanation. So I do think how assessments are undertaken is really important to review.
Can I just ask another question? And Alish, you referred to this, that the South Eastern Trust had found a magic digital solution which freed up 4,000 hours that were being repurposed. Do you want to explain that to people like us who don't really would really love to understand? Because 4,000 hours is not an inconsiderable number of hours, and you know, if those hours were lost, or were they simply taken off someone? You know, I think there's always a bit of a dilemma.
I mean, there was a pilot a number of years ago in the South Eastern Trust, and one of the outcomes of this was that they implemented Careline Live with all of their staff. So it's like a handheld rota device, but as a family you can go on and say, I'm taking my mum this evening so she doesn't need her visit, or do you know, someone's in hospital and they are going to be there for 4 days so they don't need any of their hours. So it enabled it enables real-time data, do you know, or carers can go out and log in that they've completed their visit or they haven't. But it meant that that can be done in real time as opposed to being done on paper rotas. And people, do you know, and visits, you know, people not being there and nobody knowing, so the carers calling out to the house and there, you know, not being a person there. So
and does the reallocation of those hours, and I'm presuming some of that can be on a bit of an ad hoc basis then, some of the does that work?
Yes, it is working. The South Eastern Trust are the trust that have had this in place for much longer than anybody else, and they have made it work because they are able to plan their rotas ahead for the next 24 hours and remap where staff go. And so no, it has worked. Because prior to that, you were working off a paper rota in many circumstances.
I get the fact that people...
Yeah.
So that leads me on then to ask, so in many of the trusts, if a person is in hospital for more than, I think, 2 weeks, they will essentially lose their care package. And then, and I've both personal and constituency experiences, to regain that care package when people come out of hospital with maybe actually greater needs is extremely difficult, and you kind of go to the back of the queue again. Is there any intention to review that? Because I think that is... the reason I ask about the digital solution, it seems to me that this is a perfect application to reallocate on a temporary basis, but keep that care package. Say an elderly person goes into hospital with a stroke, comes out 2-3 weeks later, maybe with even more needs, but has in the meantime lost their care package. That seems to me unfair.
It's a really difficult one because we also can't have carers. Do you know what I mean? We can't hold packages indefinitely when we have other people who need them at the other end. So, I mean, the intention from the trust and ideally is that you get to know your carers and that they've consistency and they get to know you and that package is maintained. And at the minute, I mean, it's not consistent in all the trusts, but 2 weeks is a sort of guide for how long packages will be held. And the trusts do try to give them back to the same carers again, but we just can't.
But it's not even giving them back to the same carers, it's actually getting the care package back. So in other words, you go back into the long line of people who are waiting for a care package. And hospitals are trying to get people out the door. Yeah. That person who had a care package became ill, went into hospital, maybe spent 3 weeks in hospital, has lost their care package, but actually they've come out of hospital with greater need. Or they're in hospital with greater need. I think there must be a better way of resolving that than what we currently have, and particularly in rural areas where it is really quite critical for people to have the care package in order to be able to go home.
I think it's something we certainly need to look at, Dan, as part of the reform. Some of the difficulties would be that if you retain the package but you come out of hospital with more intense needs, that provider who you've retained for 2 or 3 weeks you've been in may not be able to provide that level of support that you require. So we might have retained a package.
With one carer,
yes,
for example, and might need two.
So you could have retained that package for 2 or 3 weeks and still paid for that package, but then when you come out of hospital you need a different level of care. But you're right, the digital package is something then that we could reallocate those carers in the interim.
That gives you a little bit more ability to manoeuvre things around.
Yeah.
Surely there must be a solution to that, because it seems unfair that person who had the care package becomes ill, but then suddenly doesn't have a care package because they've been in hospital longer than the days that you allocate for that to be retained.
And I suppose some of this as well is down to how much that costs, because if we're retaining a package and continue to pay a provider for that package whilst they're not delivering to that person, there is a big cost impact of that as well, Diana, given where we are in terms of finances. But I think it's something we probably could make a commitment to look at as part of the wider reform.
So the Minister said he wanted to make social care a real living wage occupation from September. Yep. Are we on track to do that?
we're at a very advanced stage on that. A lot of the work has been done. What we're doing now is working with colleagues in Ciara's side, on the finance side, on SPPG, to say this is the model that we will build going forward, so we know then if we put an uplift on it, this is how the uplift will work year on year. I believe it is deliverable by September. We're certainly pushing very hard to have it in by September. To be frank, we have a hard deadline, Diane, on this in terms of the Western Trust first lots going live in September. So that we're working back from that at the minute, and it is a bit of a hard deadline because that it's going through a tender process at the minute, and that's when the first lots go live. So we are working as hard as we possibly can to get it in by September. The work that's been done by the Economic Policy Unit in University of Ulster allows us then to actually say, and this is the impact and this is what we expect. So we'll be able then to model the impact of that as well. So but I think September is deliverable.
And just finally then, so if we're to really make this a career pathway for people, will you then be looking at continuous professional development, training, qualifications that people can actually say that this is. I think at the moment we tend to think people do this. They're either devoted to do it or they have to do it. But we want it to be a real option, a real career pathway. So are we going to look at that within the package as well?
Yep. One of the work streams in the Social Care Collaborative Forum is around workforce, and NISC have been working with the independent sector and some of the other providers, and have recently introduced the Care and Practice framework, which is the beginning of a journey of gaining qualifications, and we would love to be able to match career development right through that. I mean, I'm a social worker. Diana, most of the social workers I know started off as social care workers in one shape or form, so we are really keen to get the Care and Practice framework implemented, really as is the independent sector. We would love to take it out to schools and take people who started off as a home care worker or a nursing assistant and have gone on to nursing or social work or any of the other AHPs, but and it's also
the department launched its workforce strategy, social care workforce strategy last December, and that is partly about delivering better pay and terms and conditions, but also better access to training and development and qualification opportunities. Diane.
And the statistics from this show that 47% of the workforce in social care are under 40. So it is becoming a younger workforce, but we need, you're right, we need to encourage
female occupations.
Mainly female,
90%,
very much so. But so and we still have quite a few over 70s in the workforce as well. You know what I mean? But we do need to make it a more attractive. And you're right in terms of career progression and some of the things we're doing in the workforce strategy as well will recognise qualifications across the sectors. So at the minute, if you work for an independent sector and do your qualifications, sometimes you go to the trust, you'll have to do them again. So we're trying to make sure that those qualifications are recognised both ways across the sectors as well, to make it a more attractive proposition for people to go into and stay into. Because pay is not the only thing will keep people in it. It is around that the real love to do the job. But if we make the job more attractive, hopefully we'll keep more people in it.
I'd really like you to come back to us on that issue of the care packages that are kind of disappearing once someone goes into hospital.
Happy to do that then, yeah.
Thank you.
Thank you, Danny.
Thank you, Chair. My experience in nursing, I have seen the sharp end of this. The lack of domiciliary care packages means patients stay in hospital for much longer than they need to when they're medically fit to be discharged. To the detriment of the patient, their health deteriorates. They're lying in a hospital bed when really they should be at home. Their mental health can be impacted by that as well, and that results in ambulances sitting outside hospitals, reduced ambulance response times, A&Es that are overcrowded, wards with hospital corridor beds stacked up in them, staff being impacted by the additional stress, patients being impacted. So there is this bottleneck is massive, and it does have a lot of wide-ranging impacts. So it's really good to see you here today and to be able to hear those answers and those answers to those questions. I have a couple of questions just about the figures in the tables. It does seem that the Northern Trust in particular, what I understand to be the largest geographical trust, seems to have a lot higher unmet need than other trusts. Is there a reason for that?
We are just, I was just discussing this with Ailey outside, we are double checking that everybody is using the same definition of unmet need. Because there appear to be two definitions at play. One is when the clock stops when a package is sourced, and then one clock stops when a package starts. So we just want to double check those figures to make sure that discrepancy isn't explained by counting two slightly different things.
No problem. It appears to confuse the figures as well, because the complex 110 code for the domiciliary care packages not being available, Northern Trust does seem to be substantially lower than other trusts.
Yeah.
So that doesn't seem to match up with the previous.
We picked up the same thing, and certainly the Northern Trust today have the least number of 8 people waiting for domiciliary care packages today. Do you know, so they do seem to be effectively getting people out of hospital and accessing packages for them. So
If these trusts are counting things differently, the data is not.
We just want to double check that sourced versus started isn't that when we're talking about unmet need, that we're all talking about package sourced versus package started. So we're just going to cleanse that.
If we could understand that all trusts are counting things in the same way, because otherwise the data doesn't mean anything.
Absolutely, no, absolutely.
And I think Encompass will help with that as well, because you're saying yourself in terms of the amount of codes for potential delays as well. There's work ongoing, I understand, to try and cleanse that down a bit and make sure there aren't as many codes, because mistakes can happen then as well. But hopefully Encompass will sort some of them.
Mark, you alluded to differences between trust employees and independent or private sector employees earlier. So there seem to be quite a lot of differences in pay rates, holiday rates, sickness, maternity, pensions, all those sorts of things. Very concerning. We seem to have a 2-tier workforce. I understand that there are steps being made to narrow and to challenge those differences. One I have quite a concern with is the sick pay. You'd mentioned sick pay as part of it, and my ears pricked up. So there are care workers who are not being paid when they're off sick. Is that correct?
That is my understanding in some of the independent sector side, that you wouldn't get paid if you're off sick. Now,
Statutory sick.
You get statutory sick, but you wouldn't get additional sick pay. So part of the work we're doing with the University of Ulster is to delve into all of that. So the surveys we sent out had a number of questions, and some of those questions were: do you get paid for your travel? Do you get paid for your travel time? Do you get sick pay? Do you get holiday pay? So that's allowing us to build the evidence base to say, here are all the issues which we believe we need to address as part of this wider package. Now, I'm not sure we'll be able to address them all, because the funding envelope the Minister has set aside as ring fence, if you like, within as an inescapable pressure this year, probably will not allow us to tick every box we want to, but nor do we believe this is the end of the process either. This is our first step in saying, in terms of stabilising the workforce and making it a more attractive profession to come into, these are the steps we're taking now. We will continue to build on that as the years go on.
That's good to hear. We do seem to have two very different, a 2-tier workforce here at the minute, and that concerns me. You have two different groups of workers who are doing the same job, both paid by the public sector in a roundabout way, but they're getting paid differently, they're getting different holidays, and the sick pay one particularly is an issue, because that puts an additional risk onto patients, because you're incentivizing people to go into work when they're sick because they don't want to lose their wages. So they're going into work with vulnerable elderly people when they may be carrying something sick. Now, I know most carers would not do that. They would not expose people to that level of risk. But there is, that's a concern, that people are losing wages when they're being sick.
I think, to be fair, the majority of the larger firms would continue to pay, and that's what's coming through in some of the data from the surveys, but there are others who probably wouldn't be as generous, I suppose is the term, in terms of continuing to pay while people are off sick.
Okay, just one other question, if the Trust does mind, or the Chair does mind. Has the Department conducted any comparative analysis of these two sectors in terms of staff turnover, staffing levels, continuity of care, quality of care, even rates of complaints in between these two sectors, between the trust employed ones and the independent private sector?
We certainly have data in terms of the numbers. NISC published data they update their dashboard every day, I think, in terms of people who are employed in the sector, and by far the independent sector outweighs the statutory sector in terms of those employed. In terms of monitoring complaints and things like that, to be honest, Danny, we haven't done that. So it's something we have never really considered as part of this reform? Or
We do, obviously we do monitor complaints, but we can't describe whether the care was from an independent
Yes.
sector often or a trust employee. You know, wouldn't
Be comparing the sectors.
well, we potentially could.
Mhm.
Could. It's not something we've looked at it in terms of, I suppose, the NISC data they collect on workforce, in terms of retention and turnover and the makeup of the workforce and the qualifications of the workforce, but we haven't got into that level of granularity around complaints or compliments, to be fair.
Or compliments,
But yeah,
no,
we'll
absolutely.
It's something we can consider,
Absolutely, yeah.
Danny, yeah, something we can consider.
We do have two very distinct sectors there. You know, one's an
Yeah.
independent private sector, and we have the statutory sector. Could I just ask one last question? Sorry, Chair. The trend was 76% independent private sector at the minute and 24% statutory. Is the trend going up? Is there an increased privatisation going on here?
That has been fairly stable, and it varies from the trust. So the Southern Trust, which Diane had mentioned earlier, 58%. They're 58% independent sector, 42% statutory sector, and that's just due to largely probably the availability of staff in that area. And then it's right up to Belfast and South Eastern Trust. Both would be over 80% in terms of their use of the independent sector. But the trends haven't really changed.
it varies around 1%.
Yeah,
year on
varies,
year.
but as an average, it's usually sort of 3/4 independent sector and 1/4 statutory sector.
One of the things we do want to look at in the future under the plan is that mixed economy of care and where the balance of that needs to lie.
What are you aiming for?
We haven't we haven't a view on it. I think we think mixed economy is important. Where the balance lies, there isn't a defined view on that at this stage, but we're committed to looking at it.
It does strike me that it's unfair. We have two different types of workers, you know, who are doing the same job and with different benefits. But thank you.
Okay, thank you. Alan? Yourself.
Thanks, Chair. Maybe that long ago, I've nearly forgot what I asked. No, it was in the back of what Nuala was asking about mileage, which Mark had kindly answered. But I'm wondering, with your permission, could I maybe expand slightly of what's within the report here? You're aware the Northern Trust today have announced the recommendation of the Trust Board to remove emergency general surgery from Causeway Hospital and transfer that to Antrim Area Hospital. I haven't met them on Monday. They're hinging that upon a number of factors, not least the pressures of staffing. They are basing the decision on their ability to provide a NIAS bypass protocol and a streamlined discharge process, as they described it. Now, Deanne and I had met with the Trust Board back in November, from memory, and we were told at that time that 25 or 26% of beds were occupied at that time in Antrim Area Hospital as a result of no discharge package being available. And I'm just wondering, on the back of that decision by the Trust Board today, what conversations you folks have had with the Trust in order to deliver this streamlined discharge process?
We've no conversations with our part of the department, so I expect that another part of the department has been involved in those discussions.
Who would that other department be?
With somebody responsible for secondary care, for example.
Fair enough. Fair enough.
Okay, thank you. So thank you very much. That was very, very useful. So appreciate you coming before us and answering all our questions. Thank you.
Thank you.
So members, content to move on then to item number 7, correspondence. So can I refer members to the correspondence list as at page 74? So the all-party group on autism, members, there's correspondence from the all-party group on autism at page 84. So the autism reviewers agreed to come before the committee on the 23rd of October, just for information. The cervical cytology review. So there's a response from the department at page 23 of tabled papers. I'm sure members are going to have comments, but we have scheduled a briefing on the 3rd of July with the Department of Health officials, SPPG, PHA and the Trust. So that's scheduled for the 3rd of July. Everybody content? Dan?
Do we know if we'll have the relevant individual screener data by that time? No.
The response from the department states that again,
indicates we're going to get something.
They're happy to brief, but we may want to schedule a briefing when that information is available. Based on what members had said previously, we thought we'd try and schedule that before summer rather than wait until that information comes, because there's no clear timeline on when that information is going to come.
Could we just ask them for a timeline? That's all. That's fine. Because if you don't keep pressurising you, it goes into the depths of the...
Okay, Royal College of Midwives. So there's an invite at page 213 from the Royal College of Midwives for members to meet with midwives from across the 5 trusts, who will be up here on the Wednesday, 18th of June. So I'm sure we'll all be at that. We're encouraged to attend at 10 a.m. when they will have an opportunity to meet with midwives. Let's hope we don't have to do another 5k run, Danny, hey?
I walked it. So.
Okay, are members content to note the rest of the suggested actions on the correspondence?
Sorry, the letter from Alma White, what was our suggested action? I can't find it now, for goodness.
Sorry, that was 7.9.
From the Committee for the Executive Office.
Yeah.
This is, adult health and social care. This is part of what we should be looking at. And I tend to think it may not be the worst thing in the world to give Alma a hearing. And then in light of the issue around respite services and so on, maybe have the officials back. I'm appreciate we probably won't get it done before July, but at some stage have them back to try. Or are we having them back?
We have respite services scheduled in, I think it's October time, off the top of my head. That was the allowed.
And we could widen that out and to hear what they are doing. I'm not on the Department for the Economy. The Department for the Economy, we're drawing together a range of the services that were available in terms of transition and what happens after school for a young adult with a learning disability. But I haven't really heard anything from the Department of Health on the issue, and there is a very wide variation of what happens. A very wide variation. So I think it wouldn't be the worst thing in the world to actually try and get a handle on it.
I would agree with Dan, but I think it touches quite a few different departments. But certainly, there is an element to health,
yes.
And certainly it would be good to hear from Alma and see how that broadens out her campaign.
Yeah. Clerk's just indicated that there was an informal meeting with Alma in January. I obviously wasn't on the committee at that point, but
it was the list of informal meetings that we had. Yeah, so it was.
Really not sure actually why the executive committee didn't take it up, since they're coordinating department across the executive as well. But that's not the reason for us
Some
not
better
to take
jokes
it
I've heard today.
I mean, certainly it's a very important issue, and it's one that needs absolutely resolved. I know the economy are probably the lead department on it, but there is education, education and health. So it might do no harm for us. I know what the protocol is, just to write to some of the other departments, including the Department of Health, just for an update on what they're doing, and then we can see where we go from there.
Just don't want it to drop off the agenda.
Oh, absolutely. So,
Chair, could I just make a quick point as well, just about the reply about the DNARs and the respect document? I think it's at 7.2.
Too busy.
Sorry? Yeah.
Because we're too busy to deal with this really important issue.
I think that's absolutely a shocking and really disappointing response, given it's been raised as a very serious issue again and again and again. I don't know where we go with that, whether we need to write back to the department, but I think that response was...
I think we this has come up through the committee's inquiry, so we will pick it up over the next couple of weeks with a couple of organisations that are coming in, and then also we have the department responding to the inquiry over 2 weeks at the end of June and early July. So I would imagine this will feature quite heavily in the committee's report.
Yeah.
So it will, and recommendations. But certainly members will be able to get in this a bit more with some of the organisations that are coming to give evidence, and then with the department when they respond to the evidence at the end of June, early July.
Sure.
Go ahead, Orly.
On 7.12 on Sherelle's letter with those updates from the I'm Not Okay families.
Yes.
It seems to be most of the feedback is around their concerns coming up to the summer months. So I can see that some of the trust's communication seems to have definitely improved. But maybe even as a committee, if it mightn't do any harm if we can write out to the trusts or to the minister just to alert them to that thread that's running out through all that feedback around their concerns over the summer, and if there is anything additional that can maybe be done over the coming weeks and months to give them a bit of help and support, because a lot of the placements seem to be, that they're coming up shortly in September and stuff, but it's just to flag their concern over the summer months, because they're still in a really difficult situation.
Whereas when you read through it, like there's still not adequate support.
No,
there's not. So I think that's a very good suggestion. And I mean, there's talk about inadequate support and broken promises. So whilst there's slight improvement, it's not what we would expect, I don't think, or certainly not what they would expect. Okay, very good point. I also just note the response from the RCN who were meeting in September, that they note the comments made by the department last week when we asked about the band 5-6 career progression, so they have serious concerns. So look forward to exploring that in more detail when they come in September. So is everybody else content then with all of those issues being dealt with as they're indicated? Okay, thank you.
See the letter from, the House of Lords, the EU inquiry. I mean, I really don't understand the detail of it. Is it possible to get a bit of a written brief from the department of the impact here?
Just point that out to me, Dan. I'm struggling.
It's the House of Lords, the Northern Ireland Scrutiny Committee.
Right, okay. Yeah, I don't. If they're going to get...
They've written to the Minister in London asking a series of questions about the impact of this under the Windsor framework.
Yeah.
And maybe the department should also give us a bit of an outline of where they see it.
As someone who used to chair the ones democratic scrutiny, I mean, they've referenced the explanatory memorandum. I used to be the dean of my Wednesdays and Tuesdays reading the explanatory memorandum, so maybe we could get a copy of that. I'm sure it's actually went to the Democratic Scrutiny Committee.
Is it possible just to get the department to decipher the explanatory memorandum?
Yep.
That, I think, would be an easier process.
Okay, everybody content? Okay, so forward work programme, draft forward work programme is page 229. So just to remind everybody, there is an informal meeting with the Pharmaceutical Society on Tuesday at 1 p.m. in room 21. I just have something else on that, I can't remember. So we'll advise of our attendance, everybody, if we haven't already done so. Also, there's a number of invitations were sent to members last week Jonathan, I was getting bleeps from you every minute, on the minute for about 10 minutes. So we were asked to respond and confirm our availability. So can we do that? And are members then content to note the briefings are set out in the forward work programme?
Sure, can I just check one there, because I know earlier we had the theme of humour, so just to keep it going, that we're a legislative assembly, and we haven't yet, nearly a year and a half in, managed any legislation. But I see that we've one down for the 12th of June, but it's only in red. I mean, can we get a sense if the department has any intention of bringing any bills this year, because it might be useful given our job and all that?
Just to say, Chair, we've been advised that the adult protection bill is, from what I hear, is going before the executive in the next week or so, and it's certainly the intention to get it in the assembly before summer. I've also been given a list of about 4 or 5 other bills that they're currently working on at various stages. So next week, I'm sure the Minister will want to outline progress on those bills, but it's just there in red at the minute until it's absolutely
they go through that
confirmed. So it is, but it was just to flag it up that there's a fair chance that we will get that before. I've asked the department as well that even if it's not, the timing doesn't work, that we would still get that briefing. So we would.
The Minister gives a 5-10 minute introduction next week. Can we ask him in that he just indicates which piece of legislation he intends to bring? And I think that way we get it on record. Fair enough.
Thank you.
Okay. So fair enough then. Everybody content with the forward work programme? Any other business? So next meeting Thursday 29th of May here at 2 p.m. Thank you all. Meeting adjourned.